الله الرحمن الرحيم. صوت كويس كده؟ بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم. في البداية طبعا كل الشكر للأستاذة الدكتورة ناجية فهمي لهذه الفكرة الرائعة والمستمرة والمثابرة في تحقيق هذا الحلم. يعني هي صحيح عندها مثابرة شديدة جدا إنها تكمل في هذا المجال، وحاجة مشرفة لينا كلنا، يعني كل الأقسام وكل الجامعات. فتحية خاصة للأستاذة الدكتورة ناجية والفريق المعاون لها، صاحب في أدب في منتهى الاحترام والود والنشاط. هنبدأ طبعا، هو زي ما الدكتورة ناجية بتقول إن المحاضرات كلها مسجلة، فهنبدأ في أول محاضرة لهذا اليوم النهاردة. الدكتورة آية زهران من قلعة الطب في الدلتا المنصورة. ما نقدرش احنا نخاف من المنصورة يعني. هو موضوع انا يعني هعرف ايه الموضوع، يعني ايه الرول اوف thickness of diaphragm in Guillain-Barré and neuromuscular or myasthenia gravis. I think it is a prognostic ولا diagnostic. انا هعرف يعني هي كده، لان دي عاملاها على في الميكانيكال فنتيليشن. يبقى prognostic and diagnostic rule of thickness of diaphragm in both myasthenia and Guillain-Barré syndrome. I think it was used for on weaning or on the patient on mechanical ventilation. And how can I do weaning? Am I right?
Yes.
Yes. Okay. Okay. Welcome. اتفضلي يا دكتورة.
السلام عليكم ورحمة الله وبركاته. الحمد لله والشكر لله to be here. It's a great honor. أشكر الأستاذة الدكتورة ناجية فهمي على إتاحة الفرصة. Assessment of diaphragmatic thickness in Guillain-Barré and myasthenia gravis using ultrasonography. This work was under supervision of Professor Sandra Ahmed. ربنا يجزاها خير يا رب عن كل اللي بتعلمه للناس. First of all, imagine that you are working continuously for 24 hours every day without stopping, exerting a very vital function, which is breathing for life. Definitely, you will say to yourself, I am very special, I am unique, I am the seat of soul, I am the diaphragm. As regards the anatomy of the diaphragm is a dome-shaped skeletal muscle separating thorax from the abdomen, and definitely it is the most important muscle of respiration. It has a costal part, sternal part, and lumbar part, and the costal part is attachment of its costal part to the lower 6 ribs. This is the zone of opposition. It means attachment of the diaphragm to the costal margin or the ribs. This is the zone of opposition. Someone will ask me, you are a pulmonologist? No, I am a neurologist. So why you are exerting or dealing with such a topic? because we have a big problem in neurology, which is neuromuscular respiratory failure. Neuromuscular respiratory failure due to many causes exerting their effects through diaphragmatic dysfunction. But unfortunately, diaphragmatic dysfunction is under-recognized. As we know much about the lung, but little about muscles pumping it. This is the causes of diaphragmatic dysfunction, and surprisingly, you will see a list or a large table of disorders causing them. Most of them in the blue color are neurological in origin, and the last line is lung causes. The causes range from central nervous system affection, motor neuron disorders, lower motor neuron disorders, including polyneuropathies, especially Guillain-Barré and demyelinating neuropathy, phrenic nerve disorder, muscles, neuromuscular junction disorder, and so on. And these disorders causing neuromuscular respiratory failure or diaphragmatic weakness or diaphragmatic dysfunction through many mechanisms, either by muscle weakness or phrenic nerve pathology, especially phrenic nerve demyelination, as in case of Guillain-Barré or acute neuropathies. What is the magnitude of the problem? It is a big problem, and we took two large entities of disorders, Guillain-Barré and myasthenia gravis, as leading causes of acute neuromuscular respiratory failure. And the incidence of cases presenting with respiratory failure and need ICU admission in Guillain-Barré syndrome range between 25 to 30%, while in myasthenia gravis from 10 to 30%, which is not a small number. Moreover, morbidity and mortality rises sharply. So the only way to addressing this or to decrease this morbidity and mortality and respiratory compromisation rate is to predict early affection of respiratory dysfunction, and to take further steps even before symptoms or clinical manifestation appear to your patient. While we're reviewing the past reviews about how the diaphragm was assessed, surprisingly, it was under-recognized, under-evaluated. They evaluated it through many techniques. First of all, clinical assessment, like follow up the clinical manifestations on the patient, like dyspnea, tachypnea, and paradoxical movement using accessory muscles of respiration. And there was a clinical predictive score, which is Erasmus Guillain-Barré respiratory insufficiency score, that predict occurrence of respiratory failure in Guillain-Barré patient. But this score validation was insufficient. It predicts the occurrence of respiratory compromisation in only 14% of patients, while the true number that occurred or the true percentages was 22%. So its validation was not satisfactory. Transdiaphragmatic pressure, which is the most accurate indicator, using phrenic nerve stimulation. Then the contraction force of the diaphragm is assessed using the assessment of the airway pressure through the endotracheal tube. This negative deflection is the normal pressure exerted by diaphragmatic contraction in normal patient. This is small deflection in diaphragmatic weakness. But unfortunately, it was an invasive maneuver, which you can't apply it in many situations or in many labs. The third test is respiratory function test. It is very important, but unfortunately, it is not sensitive to mild cases of respiratory compromisation. And a big challenge of respiratory function test application in neurological patient is it needs a cognitive, a high degree of cognition and attention, which may be, which may not present in neurological patient. Also, oropharyngeal weakness and facial muscle weakness may interfere with application of mask and causing air leak and false positive results. So this is a limitation for it. electrophysiological studies like EMG and phrenic nerve conduction studies, but they cause pneumothorax and so on. And other radiologists who were also not sufficient, so we hypothesize that ultrasonography may have a good role. Again, we have challenges. The patient may not aware of his deteriorating respiratory condition and may not show the clinical symptoms and signs of respiratory complications except late in the disease. Also, there were few recommendations from previous literatures about the prediction and the prevention and the treatment of diaphragmatic dysfunction. Also, there was a non-linear relationship between contraction of the diaphragm and the lung volume changes. So, the decrease in lung volume occurs relatively late following the development of muscle dysfunction. Also, there is a big challenge. The available screening tools are not satisfactory. So, this is diaphragmatic ultrasound. This is the technique. We use a high-frequency probe from 6 to 13 hertz and put it in the most caudal intercostal spaces, 9 or 8 intercostal spaces, spanning 2 ribs, parallel to the longitudinal axis of the body, and using B mode or M mode. In our study, we used the B mode, which is the brightness mode for the best picture. We assessed during quiet expiration and during deep inspiration. And 3 images were captured and the mean was calculated. The diaphragm appears as 3 lines, 2 hyperechoic lines representing pleura above and peritoneum below, and a hypoechoic line in between. This is the diaphragmatic muscle itself. Sometimes there is a hyperechoic line in the muscle due to dense fibrous tissue or so on. This picture shows position of the high frequency probe at the zone of opposition we told before. This is at the site of opposition zone, and this is the diaphragm as we said. Another thing in this image is this is M mode, motion mode in the technique. It allows identification of mobility of the diaphragm between inspiration and expiration, which is called excursion of the diaphragm. This is the zone of opposition, and this is M mode with the excursion of the diaphragm. This is the zone of opposition. This is the lung, this is the diaphragm. This is how we measure from the center of the upper hyperechoic line to the center of the lower hyperechoic line. This is the static measure, and this is the thickness we measured. This is the thickness at the end of deep inspiration at total lung capacity, which is called Tmax. And this is the measurement at the end of quiet expiration, which is called Tmin. This is also the M mode, which indicates the excursion and the mobility of the diaphragm. Again, M mode showing excursion of the diaphragm and the mobility between inspiration and expiration. Again, we not only measure diaphragmatic thickness only, we measure what's called the thickening ratio. It is the difference between Tmax divided by Tmin. The cutoff point for thickness is 0.15, not less than this, and the cutoff point for thickening ratio is 1.2, not less than this. Also, thickening fraction, the difference between inspiration thickness and the expiration thickness divided by in the expiration thickness. So this is 3 parameters assessed by ultrasonography. The great variability between measures and previous papers, but Boone et al. Is the most applicable by us. This case was post-COVID with respiratory compromisation, discharged from ICU with diagnosis of preliminary polyneuropathy and suspicion of phrenic nerve neuropathy. When measuring the absolute thickness, it was 0.15, which is normal, but after doing the thickening ratio, it was decreased, indicating diaphragmatic dysfunction. One may ask a question, does the diaphragm atrophy occur early? It is a skeletal muscle. Yes, the answer is yes. We can detect it early. And this paper, following patients in ICU for 1 week after admission and putting on mechanical ventilation, they found that 44% of patients developed more than 10% decrease in diaphragmatic thickness. This is the New England Journal of Medicine. Rapid disuse atrophy of diaphragmatic fibers in mechanical ventilation even after 18 to 69 hours. One may ask another question. Is there a relationship between limb muscle weakness and diaphragmatic weakness? I can say that this patient does not have diaphragmatic weakness. It is ambulant and it has not, doesn't show any signs of limb weakness. No, the answer is no. This paper shows the relationship between, or the correlation between different factors and diaphragmatic thickening ratio and Merck score, and the correlation was not significant. Another paper about the coexistence and the impact of limb muscle diaphragmatic weakness, the correlation was not significant. Also, this histogram shows the prevalence of diaphragmatic weakness in ICU in relation to ICU acquired limb weakness. The prevalence of diaphragmatic weakness is more, and it can occur before limb weakness. It also can monitor the recovery by ultrasound, and the mean period of recovery was about 14 months. In neurology, ALS disease, diaphragmatic weakness was decreased, and it was 0.17 centimeters. Like in Duchenne, the thickness ratio and diaphragmatic thickness was also reduced. This is a very important paper by bone sensitivity and specificity of diagnostic ultrasound. The same technique of us, the same maneuver, the same measurements. He found that from 82 abnormal hemidiaphragms, he found by ultrasound that 76 persons have diaphragmatic atrophy. So the sensitivity and specificity was very high. This is our work. This is our paper, neuroquantology, and we examined 3 groups: Guillain-Barré syndrome, myasthenia gravis, and control. And this rock curve showing the sensitivity and the specificity and the cutoff point of diaphragmatic thickness affection, below which respiratory compromisation occurs, was below 1.19. We found that the great affection was in Guillain-Barré group, while in myasthenia the affection was less than Guillain-Barré, meaning that the recovery was not complete recovery. This one case of our work, this is a normal Guillain-Barré case. Diaphragmatic thickness during inspiration was 0.44 centimeters, while during expiration was 0.22. And the thickening ratio here is 2, indicating that the patient is normal. It is more than 1.2. ثالث. Another case, abnormal Guillain-Barré, the thickness during inspiration was 0.36 32, while during expiration was 0.29, and the diaphragmatic thickening fraction was decreased, and the patient was affected and needs ICU admission and respiratory affection. This is myasthenia gravis patient. During inspiration, thickness was 0.27, and during expiration 0.23, and it was approaching the normal level. Take-home message: diaphragmatic ultrasound can predict respiratory dysfunction, can diagnose the diaphragmatic dysfunction, help monitor and the progression, the prognosis, help predict from weaning from ventilation, guide needle EMG, and the future diaphragmatic pacing. Thank you.
Thank you, Dr. Aya, for this great lecture and this great work. Now we go to the next speaker, Dr. Minna Talla Magdi El-Gamal. She will talk about metabolic myopathy. I think this is in our department in Champs University.
Good morning, dear colleague. Good morning, dear professor. I'd like to thank Dr. Nagia for giving me that great opportunity. Today we will speak about metabolic myopathy. About the metabolic myopathy. Metabolic myopathy is a term applied to the individually rare genetic disorder involving energy metabolism that causes muscle disease. The process of energy metabolism involves the hundreds of metabolic reactions that convert the food we consume in the forms of carbohydrates, fats, and proteins into the molecules such as ATP that drive nearly all the energy required by chemical reactions in the body. Metabolic myopathies manifest clinically as episodic condition or as a permanent, usually progressive disorder. Episodic metabolic myopathies may manifest during an episode with exercise intolerance, muscle cramps, myalgia, rhabdomyolysis, or myoglobinuria. Between the episodes, patients don't complain about muscle symptoms and the clinical neurological examination is normal. When the episodes are triggered by short, intensive strain, such as weightlifting, sprinting, or home run, the underlying defect is most likely attributable to impaired glycogen metabolism. When the episode is triggered by endurance exercise, such as hiking, biking, football, or even fasting, the underlying defect is most likely attributable to a fatty acids oxidation disorder. Permanent metabolic myopathies manifest as muscle weakness, muscle wasting, exercise intolerance, easy fatigability, myalgias, sore muscle, muscle cramps, or permanent tiredness. Now, we will talk about glycogen storage disease. Glycogen storage disease are important error of carbohydrate metabolism that affect storage, release, or consumption of glycogen. Glycogen is a branched polymer of glucose that serves as a form of energy storage for the body to be later converted into glucose. There are about 15 different types of glycogen storage disease identified based on the enzyme that is dysfunction or absent. Incidence of glycogen storage disease is estimated to be 1 per 20,000 or 1 to 43,000 per birth. Type of glycogen storage disease, they are divided into two sections. Glycogen storage disorders that primarily affect the skeletal muscles, which include muscle phosphorylase deficiency type 5, which is known as myocardial disease, phosphofructokinase deficiency, phosphoglycerate myoutase deficiency, lactate dehydrogenase A deficiency, aldolase A deficiency, beta enolase deficiency, and phosphoglucomutase 1 deficiency. Another division, glycogen storage disease that affect both skeletal and cardiac muscle include lysosomal acid maltase deficiency type 2, which is called the Bombay disease, which take our great concern nowadays, lysosome associated membrane protein 2 deficiency, glycogenine 1 deficiency, and muscle glycogen synthetase deficiency. Now we will talk about glycogen storage disease type 2, which is called Bombay disease. Bombay disease results from GAA gene mutation leading to deficient of GAA enzyme activity and progressive lysosomal glycogen accumulation. Glycogen accumulation progressively impair skeletal muscle, respiratory, smooth muscle function, and cardiac muscle function in infantile onset. Estimated overall incidence is 1 per 40,000. Estimated prevalence is about 5,000 and 10,000 patients worldwide. About the genetic of Bombay disease, acid alpha glucosidase is encoded by the GAA gene on chromosome 71 gene. Each person inherited 2 alleles. Bombay is an autosomal recessive trait. Both GAA alleles harbor a pathogenic mutation. Each sibling of a patient has a 25% chance of having Bombay disease, 50% chance of being a carrier, and 25% chance of neither being Bombay disease nor being a carrier. Here we compare the 2 types of Bombay disease, the in infant and in children and adults. Infantile onset Bombay disease usually present with symptoms within the first months of life and has a rapidly progressive disease course that is usually fatal by 1 year of age. يعني عادة الأطفال الأقل من سنة لما بيبدأ يظهر عليهم أعراض الإفكت أوف تريتمنت معاهم بيبقى مش أحسن حاجة وغالبا بيضايق. Children and adults. Late onset Bombay disease has a less rapidly and more variable disease course where symptoms may be anywhere from infancy to adult. هو عادة بيختلف البرزنتيشن ما بين الانفانتس والادلت على حسب ال percentage of activity of enzyme. زمان كان بيتقسم ل 3 types: infantile onset, children and adult onset. Nowadays احنا بنقسمه لنوعين، هو late early onset او infantile onset Bombay disease and late onset Bombay disease. حاليا ضمينا او ضم الchildren والadults في late onset Bombay disease. الانفانتايل onset result from inheritance of GAA variant leading to less than 1% of normal GAA enzymatic activity and progressive glycogen accumulation. Onset in first weeks to months of life. In late onset Bombay disease, it is results from inheritance of combination of GAA variants that together give rise to more than 1 to less than or equal 30% of normal GAA enzyme activity. عادة مش بيبقى الانزيم كله deficient، بيبقى عندنا some level of activity maintain the function of muscle. Onset often not always post infancy. In infantile onset Bombay disease, infants with infantile onset historically don't achieve motor milestones or independent sitting, creeping, standing, or walking. Infant typically present with cardiomegaly, hypotonia, rapidly progressive skeletal muscle, and respiratory distress, muscle weakness, feeding difficulty, and failure to thrive. عادة الأطفال اللي بيتولدوا ب infantile onset Bombay disease بيتولدوا as a floppy baby. يعني البومبي بيخش as a differential diagnosis in floppy baby. عشان كده الانزيم لما بيبقى قليل جدا التريتمنت او الانزيم ريبليسمنت ثيرابي ما بيجيبش نتائج كويسه في الاطفال with infantile onset Pompe disease. In late onset Pompe disease, untreated late onset Pompe disease leads to impaired function, wheelchair, ventilator dependency. على حسب الليفل اوف اكتيفيتي اوف انزيم بنتوقع يعني او بيبقى المانيفستيشن بتظهر امتى. كل ما كان الليفل قليل كل ما المانيفستيشن ظهرت في سن بدري. بيبقى فاريبل ما بين بيشنتس للتاني، بس كل ما كان الانزيم اعلى كل ما ادانا ريزلت احسن في الانزيم ريبليسمنت ثيرابي. Second type of metabolic myopathies is a fatty acid storage disease. Lipid storage myopathies are a heterogeneous group of genetic disorder characterized by pathological lipid accumulation in muscle fiber. They are characterized on morphological group by accumulation of lipid droplets in muscle as well as in other tissue due to several biochemical or molecular defects. The classification of lipid myopathies انواع كتيره جدا بتختلف على حسب الانزيم الديفيشنت. بس في there are four types of diagnosable lipid storage myopathies that always present with an abnormal storage of neutral lipid typically in muscle. Most common primary carnitine deficiency, multiple acyl CoA dehydrogenase deficiency, neutral lipid storage disease with exosis, neutral lipid storage disease with myopathies. Some lipid storage myopathies can be managed by an appropriate diet and a cofactor supplementation. For example, primary carnitine deficiency patients show a dramatic improvement with a high doses of oral carnitine supplementation, while most patients with late onset multiple acyl CoA dehydrogenase deficiency are responsive to treatment with riboflavin and coenzyme Q. Now we will talk about primary carnitine deficiency. Primary carnitine deficiency syndromes are a rare biochemical disorder and can be classified on the basis of clinical and biochemical criteria in muscle carnitine deficiency and systemic carnitine deficiency. لو السيمتومز في البرايمري كارنيتين ديفيشنسي concerned اكتر بالمصل فهو ده بيعتبر برايمري كارنيتين ديفيشنسي ان مصل. سيستميك السيمتومز بتتخطى حاجز السكيليتال ماسل وتأفكت الليفر والكاردياك ماسلز. A carnitine deficiency syndrome should be suspected in a patient when followed with following symptoms are present: myalgias, fluctuating weakness, hypoglycemia with or without ketoacidosis, with a Ray-like syndrome, abnormal fatigability, cardiomyopathy with left axis deviation. Third type is the mitochondrial myopathies. Mitochondrial disease are caused by deficient in mitochondria, which are energy factories found inside almost all cells in the body. Mitochondrial disease that cause a prominent muscle problem are called mitochondrial myopathies, while mitochondrial disease that cause both a prominent muscle and neurological symptoms are called mitochondrial encephalomyopathies. Mitochondrial disease are caused by genetic mutation. Gene provides the instructors for making proteins, and the gene involved in the mitochondrial disease normally make proteins that work inside the mitochondria. First division for mitochondrial myopathies are myopathy. The main symptoms of mitochondrial myopathies are muscle fatigue, weakness, and exercise. The severity of these symptoms varies greatly from one person to the next, even in the same family. In some individuals, weakness is most prominent in muscles that control movement of eye and eyelids. Two common consequences, the gradual paralysis of eye movement called progressive external ophthalmoplegia, and the drooping of the upper eyelid called ptosis. About the mitochondrial encephalomyopathy, a mitochondrial encephalomyopathy typically include some of symptoms of myopathy plus one or more neurological symptoms. It can affect the eye itself and parts of the brain involved in vision. For instance, vision loss due to optic atrophy, retinopathy, is a common symptom of mitochondrial myopathy. Sensorineural hearing loss is a common symptom, although mitochondrial disease also can cause ataxia. Other common symptoms of mitochondrial encephalomyopathy include migraine and seizures. Our project in Ain Shams University, especially in our neuromuscular unit, is to detect the patients and study the characteristics of metabolic myopathy. Usually ما فيش registry لعيانين الميتابوليك مايوباثي، فاحنا قررنا الفترة الأخيرة إن احنا نحاول ندايجنوز these patients for the emerging therapy. حاليا بقى عندنا treatment لنوع من أنواع الميتابوليك مايوباثي اللي هو البومبي ديزيز وبقى available. ف يعني دكتور ناجية مشكورة يعني بتقدم لنا البروجكت ده عشان to aid the patients.
Could you repeat, translate to English because the most visitors.
Okay. Hierarchy for diagnosis. First, we depend on the clinical and neurological assessment by clinical history and examination. Most patients which suspect metabolic myopathies include the exercise intolerance, permanent muscle weakness, respiratory affection, attacks of micropynuria. All of these symptoms, we can, in the presence of all of these symptoms, we can suspect metabolic myopathy. Second step is a laboratory investigation in the form of CK, thyroid profile and thyroid function, electrolytes like calcium, sodium and potassium, vitamin D, lactate and pyruvate, to exclude any other causes that may cause muscle weakness or exercise intolerance. Third step is the EMG. Fourth step is MRI muscle, whole body, if it is not contraindicated. MRI muscle can suspect the pattern of involved muscle in the MRI. We can suspect we can put a differential diagnosis for the disease. Like in Pompe disease, we can suspect it when the affected muscle in the MRI involves the upper thigh anterior compartment, especially the adductor magnus, in the shoulder girdle supraspinatus muscle, and paraspinal muscles and respiratory muscle in the MRI. Muscle biopsy and histochemistry, dried blood spot for patients suspected for Pompe, and last step is the genetic examination. We started our project in July 2021, and up till now, according to the clinical and radiological and laboratory criteria, we are able to diagnose 3 patients with late onset Pompe disease who are receiving myozyme at our neuromuscular unit in cooperation with Sanofi company. 1 patient diagnosed with debranching enzyme deficiency, type 3 glycogen storage disease. 1 patient diagnosed with primary carnitine deficiency, and 3 patients diagnosed with mitochondrial myopathy depending on the muscle biopsy. Thank you.
Thank you, Dr. Minatalla, for this presentation. I know the subject is very wide and hard, and it's a textbook by itself, but thanks. And now we shift to Dr. Osama Yaqub. He will talk about, from Cairo University, he will talk about toxic and endocrinal myopathies.
السلام عليكم، صباح الخير. اولا احب اشكر الدكتوره ناجيه فهمي على الاستضافه، وشكرا للشركه المنظمه. ان شاء الله هنتكلم على الاندوكراين والتوكسيك مايوباثيز باذن الله. طيب اهميه موضوعنا ان احنا عندنا المايوباثيز زي ما حضراتكم عارفين ان احنا عندنا برايمري.
Please, can you speak English? Because
as we know, the myopathies, يعني the major divisions of myopathies include the hereditary or primary myopathies and acquired or secondary myopathies. Usually we search for secondary causes of myopathies, as the secondary causes may be treatable. دايما نخلي في بالنا واحنا بنتعامل مع عيان المايوباثي ان احنا بنحاول ندور على treatable causes، فلازم نخلي في بالنا موضوع الهيستوري تيكينج، يبقى ديتيلد هيستوري تيكينج، ونفكر في الدراج ابيوز او الميديكيشنز اللي احنا بنستعملها كتير في حياتنا اليوميه. يعني لو المعلومه او لو الدراج مش في المايند احنا مش هنقدر ندور عليه، لازم نبقى احنا عارفين ايه الدراجز اللي ممكن تعمل توكسيك مايوباثيز. we search for dose and duration of يعني disease او في drug use، ونسيرش for other comorbidities اللي ممكن تكون مصاحبه للدراج او للتوكسيك اللي احنا التوكسيك اكسبوجر. The pathogenic mechanism of toxic myopathies include first necrotizing myopathies، ده بيحصل مع حالات الستاتينز and other cholesterol lowering agent والسايكلوسبورين والبروبوفول واللابيتالول والالكحول. Second mechanism inflammatory myopathies، ده بيحصل مع الاميون تشيك بوينت انهبيتورز، دي بنسلامين فينوتوين انترفيرون الفا. انتي مايكروتيوبولار، ده بيحصل في مع حالات الكولشيسين اكسبوجر. والميتوكوندريال مايوباثي مع الانتي ريتروفيرال ميديكيشنز زي الزيدوفيدين والتلبوفيودين. والانفوفيليك ميديكيشنز زي الاميدارون والكلوريكين والهيدروكسيكلوريكين بتنترفير مع السيل ممبرين بتاع المصل. طيب احنا التوكسيك مايوباثيز في large number of exogenous agents especially various medications associated مع المصل disease mostly بتبقى infrequent complication، يعني most of the cases الدراجز دي مش بتعمل المايوباثيز as a frequent cause of the frequent side effect، بس should be kept in mind and high index of suspicion is required, many of which improve after stopping the offending agent, but sometimes we need specific and timely يعني time يعني limited treatment may be required in some cases as in الحالات بتاعه الانتي HMG كوير ريدكتيز اللي بتبقى معاها الاميون الستاتين اميون ميديتد نيكروتايزنج مايوباثي. الكلينيكال مانيفستيشنز اوف توكسيك مايوباثي يعني بتتراوح، بتبقى رينج من المايلد سيمبتومز زي الميالجيا او كرامبس الى اكيوت او سيفير نيكروتايزنج مايوباثي مع ويكنس او مايجلوبينوريا، ممكن تؤدي لايف ثريتنينج رينال فيلير. السيمبتومز ممكن تبدا برضه بتتراوح الرينج، ممكن تبدا مع الانيشيشن اوف تريتمنت على طول، وممكن تبقى مانثز او ييرز افتر دراج اكسبوجر. عاده اليوجوال برزنتيشن بيبقى سب اكيوت بروكسيمال ويكنس. طيب الكلينيكال كلوز اللي ممكن تخلينا نفرق الايتيولوجيز، لان ممكن تبقى بتتلخبط احيانا التوكسيك مايوباثيز مع الانفلاماتوري مايوباثيز. الاذر اسوشيشنز بتاعت اول حاجه ان احنا يبقى عندنا اصلا الدراج او التوكسيك اللي احنا بندور عليه، والاذر اسوشيشنز بتاعت السيمبتومز بتاعته، زائد لو بيعمل مانيفستيشنز ثانيه. ودايما نخلي في بالنا ان احنا ندور على اذر توكسيك اكسبوجر، لان ممكن واحد يكون بياخد 2 ميديكيشنز والاثنين مع بعض يكون هم بيعملوا مش واحد بس. طيب اول حاجه الستاتينز، the most common class of medications associated with myopathic disorders، برضه بتبقى رينج من الاسيمتوماتيك هايبرسيكيميا، بعدين ممكن مايالجيا او كرامبس، بعدين ممكن تبقى توكسيك نيكوتايزنج مايوباثي تؤدي الى رابدومياليسيس ورينال فيلير زي ما احنا قلنا. ممكن تبقى ميكانيزم تاني خالص اللي هي الاميون ميديتد نيكوتايزنج مايوباثي، ودي بتحتاج ريكواير اميون ثيرابي، لان دي بتبقى عن طريق انتي بوديز اجينست الاتش ام جي انتي اتش ام جي كويردكتيز. طب الفاكتورز اللي بتزود الريسك اوف مايوباثي اسوشيتد مع الستاتين اكسبوجر، الاولدر ايج اباف 65 years، والليفر اند رينال فيلير، والهايبوثايرويد، والاوبيزيتي. وفي ديفرنت ستاتينز بتبقى اسوشيتد معاها المايوباثي اكتر من ستاتينز ثانيه زي الفلوفاستاتين والبرافاستاتين، وبتبقى اقل مع الروزوفاستاتين، وبتبقى دوز ديبندنت، وبتبقى اكتر مع الكو ادمنستريشن اوف ميديكيشنز اللي بتزود الستاتين ليفل زي الاتورفاستاتين والسيمفاستاتين واللومفاستاتين، بتبقى ميتابولايزد باي سيتوكروم بي 450. والدراجز ميتابولايزد باي سيم انزيم بتزود الريسك وبعض الادويه الاسوشيتد اللي ممكن تبقى بتتاخد مع البيشنت زي الكالسيوم شانل بلوكرز والانتيبيوتكس وبعض الانتي فانجلز والانتي ريتروفيرالز والانتي ديبريسنت والاميونو سبريسنت، زي ما احنا قلنا ان احنا ندور على الكو اكسبوجر لاذر ميديكيشنز، والبوليمورفيزم وذن الاس ال سي او بي 1 جين. طب ايه لما نلاقي توكسيك مايوباثي مع اسوشيتد مع الستاتين نعمل ايه؟ اول حاجه نحاول نتشينج الستاتين لحاجه بتكون السايد افكت بتاعتها اقل شويه، او نبدا ندي نون ستاتين ليبيد لورنج ايجنت، وممكن نعمل يعني نون ديلي ستاتين يوز، يعني بتبقى دي افتر دي، او ممكن نقلل الدوز بتاعه الستيم ستاتين. طيب لو احنا افتر ديسكونتينويشن اوف ستاتين ممكن الدنيا تتحسن في خلال اسابيع بسيطه، وممكن تخليها ايه تستنى فور 2 مانثز او مور. طيب المايوباثي لو احنا عملنا الكلام ده وما تحسنش، نبدا نفكر في الاميون ميديتد ميكانيزم زي ما احنا قلنا، وده بيحتاج اميون ثيرابي بالاي في اي جي والاستيرويدز. الاذر ليبيد لورنج ميديكيشنز ممكن تعمل توكسيك مايوباثي، بتبقى عاده مع يعني في الفايبريت ميديكيشنز، واهمهم واشهر واحد اللي هو الجين فايبروزين. ده بيبقى بينترفير مع الستاتين ميتابوليزم وبيزود يعمل 15 فولد انكريز ريسك اوف رابدومايوليسيس. الريسك برضو بيزيد لو احنا بنستعمل اذر ستاتين، لو هو الفايبريتس مع الستاتينز، او لو كان البيشنت عنده رينال فيلير او بريفيوس ستاتين انديوزد رابدومايوليسيس. المانجمنت ان احنا نحاول نقلل الدوز ونستعمل كلاس تاني من الليبيد لورنج ميديكيشنز، بس عاده الريسك بتاع الريكارنس بيبقى هاي. سكند ميديكيشن او ثيرد ميديكيشن الديبينسلامين، بنستعمله في حالات الويلسون، ده ممكن يعمل بوليمايسايتس او درماتومايسايتس، واحيانا بيبقى اسوشيتد معاه راش كمان. نخلي بالنا في الاستعمال بتاعه ان في حالات من ابتو من ل 1.5% ممكن يحصل معاهم المايوسايتس، بس مع الديسكونتينويشن بيبقى فيه فول ريكفري. طب الاميودارون بيستعمل كتير جدا في الكاردياك بيشنتس، هو انتي اريثميك ميديكيشن، فالريسك بيزيد معانا مع الديوريشن اوف تريتمنت ولا في رينال فيلير. والاميودارون بيعمل نيورولوجيك ونون نيورولوجيك مانيفستيشنز. في حالات النيورولوجيا كمايوباثي بتبقى رير، بس ممكن يعمل حاجات تانية في النيورولوجي زي البريفرال نيوروباثي، الاتاكسيا والتريموز والديسفيجيا. لو عمل مايوباثي نخلي بالنا ان ممكن يبقى نتيجه الهايبوثايرويد الاسوشيتد مع الاميودارون، يعني الاميودارون بيعمل نيورولوجي ونون نيورولوجي، فممكن لو عمل الهايبوثايرويد في حد ذاته يا اما بيبقى هو اللي عامل البروكسيمال ويكنس، او ممكن يقاد للبروكسيمال ويكنس الاسوشيتد مع الاميودارون يوز نفسه. بس عاده مع الاميودارون بيحتاج برولونجد اكسبوجر وبيتحسن لما نوقف الميديكيشن. الاميون سبريسيف دراج زي السايكلوسبورين والتاكرولوميز هما الاثنين ممكن برضه يبقى اسوشيتد معاهم مايوباثي، وممكن كمان التاكرولوميز يعمل كارديو مايوباثي. طب الانتي ريتروفيرال ميديكيشنز اشهرهم وهو الاساسي الاولاني اللي هو الزيدوفيودين عن طريق الميتوكوندريال مايوباثي زي ما احنا قلنا في الاول في الميكانيزم بتاعه، بس نخلي بالنا ان الاتش اي في نفسه ممكن يعمل بروكسيمال ويكنس وممكن يعمل بروكسيمال ويكنس، بس الفرق بيبقى الميالجيا بتبقى اكتر مع الزيدوفيودين، يعني عشان نفرق ما بين الاتش اي في مايوباثي او الزيدوفيودين مايوباثي. التلبوفيودين ده انتي اتش الهيباتيتس بي فيروس، ممكن يعمل نيوروباثي اند مايوباثي، ونخلي بالنا ان ده بيزيد في حالات الرينال فيلير والليفر فيلير. والاذر انتي ريتروفيرال ميديكيشنز الكلوروكين والهيدروكسيكلوروكين مايوباثي. الكلوروكين بيستعمل كانتي مالاريال، وهما الاثنين بيستعملوا مع الكونكتيف تيشو ديزيز، والانتي مالاريال برضه بيعملوا ويكنس، بس عاده بيبقى مع البرولونجد اكسبوجر، ونخلي بالنا ان ممكن يبقى معاهم نيوروباثي، فممكن في الاكزامينيشن نلاقي ديمينشد انكل ريفلكس وسنسور لوس. الكولشيسين مايوباثي انتي جاوت ميديكيشن، ده بيعمل عن طريق الانتي مايكروتيوبولار ميكانيزم، بيبقى عاده مع البرولونجد اكسبوجر، ونفس الكلام بيزيد مع الايج ومع الرينال insufficiency ومع الكونكوميتنت يوز اوف اذر ميديكيشنز اللي هي اللي مع السيتوكروم بي 450 انهبيتورز. الالكوهول مايوباثي ممكن يعمل نوعين، الالكوهول ممكن يعمل الصوره الاساسيه بتاعته اللي هو الكرونيك مايوباثي مع البرولونجد اكسبوجر لسنين، وبيبقى كميه كبيره جدا زي يعني اب تو من 100 to 300 جرام بير داي، يعني مع 20 سنه، ده الاساسي وده الكلينيك، ده الصوره الاساسيه بتاعته. لكن مع البنج الكحول ممكن يعمل اكيوت مايوباثي، بتبقى معاها رابدومايلوسيس وممكن تعمل رينال فيلير. الاسترويد مايوباثي يعني عندنا زي ما هنشوف في الاندوكراين كمان الاسترويد مايوباثي ممكن تعمل بروكسيمال ويكنس واتروفي، عاده بيبقى لور لمب اكتر من الابر لمب. ندور على الاذر فيتشرز عشان نقدر نوصل للتشخيص بتاعنا. عاده بتبقى دوز ديبندنت وتايب ديبندنت. الفلورونيتد كورتيكوستيرويدز بتبقى اكتر، والدوز ديبندنت لو احنا 30 مللي جرام بير داي او مور من الايكوفالنت البريدنيزولون. الميكانيزم عن طريق اللي بتقلل البروتين سينثيز والكربوهيدرات ميتابوليزم والميتوكوندريال ديسفانكشن. ونخلي بالنا من نقطه مهمه ان الاستيرويد بتستخدم في علاج بعض حالات المايوباثي في الانفلاماتوري مايوباثي. فهل هي استيرويد مايوباثي ولا هو اكسسربيشن للاندرلاينج ديس اوردر؟ على حسب. هنخلي بالنا من الباترن اوف ويكنس. الديستال اند فيشيال الاوكلوموتور ماسلز بتبقى سبيرد في الاستيرويد مايوباثي، لكن ممكن تبقى موجوده في الانفلاماتوري مايوباثي اللي احنا بنعالجها. وطبعا اللي بيفرق معانا في السي بي كي ليفلز بيبقى نورمال في الاستيرويد مايوباثي والاي ام جي. طب نعمل ايه لو احنا مش متاكدين؟ هنبدا نوقف. لو العيان مثلا انفلاماتوري مايوباثي وبياخد استيرويد واحنا مش عارفين ايه اللي حاصل، هنبدا نقلل الدوز بتاعه الاستيرويد. لو اتحسن يبقى دي كانت استيرويد مايوباثي، لو لسه سيمبتومز مش ما اتحسنتش يبقى ده اكسسربيشن للاندرلاينج ديس اوردر. الماسل بايوبسي عاده مش بتفيدنا في التشخيص. الانتيتي اللي بعد كده الكريتيكال إلنس مايوباثي. الكريتيكال ال بيشنتس في الاي سي يو بيبقى في عندهم لايبل ان هم يديفلوب حاجتين، الكريتيكال إلنس مايوباثي والكريتيكال إلنس بولينيوروباثي، او ممكن الاثنين. طبعا المور كومن الكريتيكال إلنس مايوباثي ممكن تبقى اكزيست، ممكن يحصل هما الاثنين مع بعض. يعني ممكن كريتيكال إلنس مايوباثي او كريتيكال إلنس بولينيوروباثي او مع بعض. عاده بتبقى مع السبسيس والمالتي اورجان فيلير. الباثوجينيسيس ستيل انسيرتن، بس كان كلام مشهور قبل كده ان هم لهم علاقه بالكورتيكوستيرويد والنيوروماسكولار بلوكينج ايجنت، بس الكلام ده مش متاكدين منه حتى الان. البرزنتيشن المايوباثي بتبقى عاده بروكسيمال، والنيوروباثي بتبقى عاده ديستال ومعاها سنسوري لوس. المايوباثي بتتحسن اسرع، بيريكفر اسرع من النيوروباثي او الكومبايند فيتشرز. وبنفرق بالاي ام جي والبايوبسي. الاميون تشيك بوينت انهبيتورز بيستعملوا في علاج الكانسر من الادويه الحديثه اللي بتستعمل في الكانسر كيموثيرابي. نخلي بالنا منهم ان احنا لو حد بيستعمل الحاجات دي فهم ممكن يعملوا يعني حاجات كتير في النيورولوجي، اشهرها النيوروباثي، وممكن تعمل انكفالوباثي، وممكن تعمل مايوباثي. المايوباثي بتاعتها بتنفولف الاكزيال ماسلز، وممكن تاخد البروكسيمال اكستريميتيز، ممكن تعمل سيفير ريسبيراتوري ماسل ويكنس ويحتاج ميكانيكال فنتيليشن. ونخلي بالنا انها ممكن تعمل بالبر واوكيلوموتور مايوباثي، وده لخبطنا مع المايسينيا جريفز، وهم نفسهم الاميون تشيك بوينت انهبيتور ممكن يعملوا مايسينيا جريفز لايك. يعني هم بيعملوا مايوباثي وبيعملوا مايسينيا جريفز الاثنين، فنخلي بالنا ان هم ممكن يحصل اوفرلاب ما بينهم. العلاج ان احنا بنوقفهم ممكن نحتاج اي في اي جي، ممكن نحتاج استيرويد، ممكن نحتاج بلازما اكستشينج، وبتحسنوا بعد ما نوقفهم. طيب الاندوكراين مايوباثيز. الاندوكراين مايوباثي بتبقى مشهوره مع حالات الثايرويد ديسفانكشن بانواعها، والباراثايرويد والرينال ديستربنس والاكروميجالي، الدايابيتس والجونادال ديسفانكشن والكارسينيت سيندروم. اشهر حاجه بتبقى موجوده في حالات الثايرويد ديسفانكشن في الهايبو والهايبر ثايرويد. طبعا بنفرق بالمانيفستيشنز الاسوشيتد، والعلاج بيبقى في الهايبوثايرويد ان احنا ثايرويد سبلمنتيشن، وفي الهايبر ثايرويد ان احنا بنعالج الكوز. الثايرويد اوفثالموباثي اللي بيبقى اسوشيتد مع الجريفز ديزيز بيبقى ريستريكتيف اوفثالموباريسيس، وده بيحتاج اميون ثيرابي. والثايروتوكسيك بريودك باراليسيس بيبقى معاه، بيبقى زي الهايبوكاليميك بريودك باراليسيس، فبيبقى معانا هايبوكاليميا، والعلاج بتاعنا بنعالج الثايرويد ستيت وبنعالج الايه وبندي بوتاسيوم. الباراثايرويد ديسفانكشن في البرايمري هايبر باراثايروديزم ممكن يحصل هايبر كالسيميا وهايبوفوسفاتيميا وهايبر ماجنيزيميا. الهايبر كالسيميا والهايبوماجنيزيميا ممكن يعملوا انكفالوباثي هالوسينيشنز، وممكن يحصل لمب جيردل ويكنس. في الهايبوفوسفاتيميا ممكن بعض الحالات النادره ممكن يحصل سيفير مايوباثي ونكروتايزنج مايوباثي ورادومايوليسيس. الهايبوباراثايرويد والفيتامين دي ديفيشنسي مش مشهور قوي عنهم ان هم يعملوا المايوباثي، بس بيعملوا اكتر النيوروباثي وسيركم اورال بارثيزيا، بس ممكن يعملوا ماسل ويكنس. الديستربنس بتاع الادرينال اكسس كله من اوله لاخره ممكن يبقى اسوشيتد مع المايوباثي، زي ما احنا قلنا الاكسسيف ستيرويدز، زي ما احنا قلنا ممكن تبقى اكسوجينس، كمان ممكن الاندوجينس ستيرويد ممكن تعمل في حالات الكوشنج لو في ادرينال تيومرز، لو في اكتوبيك ادرينوكورتيكوتروبيك هرمون برودكشن او بيتيوتري ادينوما. الادرينال انسفشنسي في حالات الاديسون والبايلاترال ادرينالكتومي ممكن يبقى اسوشيتد معاهم مايوباثي. في الاديسون بيبقى عن طريق الهايبوكاليميا الهايبركاليميا. طيب المانيفستيشنز بيبقى بروكسيمال ماسل ويكنس ويستنج، ممكن يبقى في اذر نيورولوجيكال مانيفستيشنز زي ديبريشن فاتيك سايكوزيس، والعلاج بيبقى تريتمنت اوف ذا كوز والانفستيجيشنز از يوجوال. الاكروميجالي مع الاكسسيف جروث هرمون سكريشنز ممكن يبقى فيه مايوباثي، ممكن يبقى فيه بروكسيمال نيوروباثي، والانفستيجيشنز از يوجوال. والدايابيتس ممكن يعمل فوكال مايونيكروزس، هو المشهور اكتر انه بيعمل نيوروباثي بس ممكن يعمل مايوباثي. والكارسينويد سندروم ممكن يبقى اسوشيتد مع المايوباثي، بتبقى اميون ميديتد. شكرا جزيلا.
Thank you, Dr. Osama. Please finally we'll present Dr. Dua Atif to tell us about the dystrophic and not dystrophic myotonias.
بسم الله الرحمن الرحيم. هتكلم النهارده عن الديستروفيك and non-dystrophic myotonia. My agenda today will involve dystrophic and non-dystrophic myotonia. هتكلم in brief عن introduction, types, pathogenesis, clinical features, and finally management and treatment. According to myotonia، لما يجي لي عيان عنده myotonia أول حاجة هفكر فيها إيه؟ إن عندها هيبقى عنده delayed muscle relaxation. العيان ده manifestation wise يقول لي يا دكتور أنا لما بمسك الأكرة جامد ما بعرفش أفك إيدي، أو سلم على حد بحرارة ما أعرفش أفك إيدي منه. البوينت الثانيه ان هي بتخضع لقانون اسمه وورم اب فينومينا. يعني ايه؟ العين ده محتاج يعمل continuous movement عشان الدنيا تفك معاه. واخيرا عدوها الكولد. العيان ده لو exposed للكولد العيان ده هيبقى manifesting very badly. طيب بالنسبه للمايتونيك ماسكولار ديستروفيز بقى ايه؟ هم عباره عن تراياد. يعني ايه تراياد؟ العيان بتاع المايتونيك ديستروفي ده هيبقى عنده progressive muscle weakness، هيبقى عنده مايتونيك فيتشرز زي ما هنتكلم عنها، هيبقى عنده early onset cataract. early onset cataract قبل سن ال 50 سنه. طيب تو تايبس عندنا دي ام 1 اللي هو ديستروفيك مايتونيا تايب 1 وديستروفيك مايتونيا تايب 2. لو هنتكلم عنهم عشان الوقت بتاع المحاضره هنعمل comparison. both of them المفروض ان هم inherited عن طريق autosomal dominance. طيب النقطه الثانيه احنا عندنا الجينيتك افكشن على مستوى الدي ام 1 احنا عندنا تراي نيوكليوتايد اكسبانشن اللي هو سي تي جي، على مستوى الدي ام 2 هو تترا نيوكليوتايد اكسبانشن. هنا كروموزوم 19 هنا كروموزوم 3، والجين في الدي ام 1 دمبك جين وهنا سي ان بي بي جين. طيب يعني ايه بس كلمه ستيبل وان ستيبل اللي موجوده هنا؟ ان احنا ستيبل معناها ان هو الاكسبانشن بتاعي موجود اول ثرو بقيه الماسل سيلز، انما الانستيبل اكسبانشن معناه ان هو اوفر تايم مع الايجينج بيبدا يزيد في النمبر بتاعه. طيب الانتسيبيشن موجود في دي ام 1 وانتسيبيشن مش موجود في دي ام 2. يعني ايه؟ يعني subsequent generations at younger age هيبدا العين يمانيفست وهيبقى عنده سيفير ايه؟ سيفير كورس اوف ذا ديزيز. هنا بيبقى جلوبال او وورلد وايد برزنتيشن. هنا اليوروبيان بوبيوليشن بيبقى مين اللي عندهم الدي ام 2. طيب بالنسبه للنمبر اوف ريبيتس المفروض ان احنا الكابس بتاعه الدي ام 1 من اول 50 لحد في بعض الناس ديتكتد 4000 كوبي، انما الدي ام 2 بيبقى من 75 ل 11000 كوبي. طيب هل بيبقى في كورليشن ما بين النمبر اوف ريبيتس في دي ام 1 او دي ام 2؟ ايوه، دي ام 1 قال لك كل ما ريبيت النمبر بتاعها هيزيد معناه ان العيان ده هيبقى عنده سيفير كورس اوف ذا ديزيز. على سبيل المثال ان احنا عندنا البوزيتيف، عندنا هنا الكونجنتال والتشايلد هود اونست اوفر 1000 ريبيت. طيب لو اقل شويه نمبر اوف ذا ريبيتس هيبقى ساعتها ادلت اونست او ليت اونست. انما في الدي ام 2 لا، هو المين ايج بتاعهم اراوند 48 years، لكن ما بيبقاش عندهم كورليشن ما بين الايه؟ النمبر اوف ريبيتس اند ايه؟ اند مانيفستيشن. طيب عشان نتكلم عن الباثوجينيسيس كده هتكلم عن دي ام 1 بس، ودي ام 2 تباعا هيبقى نفس القصه. احنا عندنا دي نورمال سيل. النورمال سيل بيبقى فيها في الدمبك جين اللي موجود في الكروموزوم 19 بيبقى عندنا سي تي جي تراي نيوكليوتايد ريبيت موجود. المفروض ان هو يبقى ترانسكريبتد في الار ان اي الى سي يو جي، ده مسؤول عن ان هو يطلع لي نورمال مابنل، ده عباره عن سبلايسنج ريجيليتور، ويطلع لي حاجه اسمها سي يو جي بيس بير يبقى فوسفوريليتد بشكل معين، والاثنين دول يشتغلوا في السبلايسنج صح. طيب ايه بقى اللي بيحصل في عينين الدي ام 2؟ ان انا عندي سي تي جي اكسبانشن، تباعا هيبقى في الترانسكريبتد ار ان اي هيبقى عندي سي يو جي سي يو جي سي يو جي، هيبقى اكسس سي يو جي. ساعتها ايه اللي هيحصل؟ هيحصل سيكوستريشن للمبنل ده، هيبقى ساعتها سيكوستريتد مش هيقوم بالوظيفه بتاعته، وبالتالي كمان هيبقى عندي هايبر فوسفوريليشن السي يو جي بيس بير، فساعتها ده برده مش هيشتغل كويس. دول الاثنين المسؤولين عن المانيفستيشن بتاعت المايتونيا. يعني المبني اللي هو هيبقى سيكوستريتد ده هيبقى مسؤول عن ان انا هيبقى عندي كلورايد شانل ابنورماليتي، هيبقى مسؤول عن المايتونيك فينومينا. والناحيه الثانيه الفوسفوريليتد سي يو جي ده بيس بير هيبقى مسؤول عن الاذر سيستم او الاكسترا ماسكولار مانيفستيشن. ومن هنا جت الافكار بتاعه التريتمنت، ان احنا بنفكر ان احنا ندي مثلا انتي سنس اوليجونيوكليوتايد يمسك في الاكسبانشن اللي موجود هنا، او يمسك في الاكسبانشن اللي موجود في الترانسكريبتد ار ان اي، او ان انا اعمل انزيماتيك ديجراديشن للميوتنت ار ان اي ده، او ان انا ابدا اعمل ريجيليشن اب للمبنى اللي هو المفروض بيبقى حصل له سيكوستريشن هنا، فابدا ادي العيان زي كومبنسيشن، او ان انا ادي بروتين كاينيز يمسك في الهايبر فوسفوريليتد سي يو جي اي بيس بير. طيب هنكمل بقى الكلينيكال بيكتشر. هنبص على الرسمه دي هتختصر كل حاجه. لو دي ام 1 عندي ديستال افكشن، يعني عندي الفينجر فلكسرز، عندي الدورسي فلكسرز اوف ذا انكل، وعندي باي فيشال ويكنس. من ناحيه الدي ام 2 بيبقى عندي بروكسيمال افكشن. في حاجه او بوينت مهمه جدا، ان الماسل بين فيري كومن مانيفستيشن في الدي ام 2، وكتير جدا ممكن نمس في البراكتس. يعني عيانه تبقى جايه، كتير بنشخص حالات بنات فايبروميالجيا، وبعدين نلاقي ايه العيانه ممكن لو دخلنا عليها علاجات من ممكن تحسن المايتونيك فيتشرز دي، نلاقي العيانين اتحسنوا. ولو طلبنا لهم اي ام جي ممكن يطلع لنا الكتريكال مايتونيك ايه فينومينا. طيب بالنسبه للمايتونيك فيتشرز في الدي ام 1 بتبقى فيري اوبفيوس، انما دي ام 2 بتبقى ليس اوبفيوس، اللي هو البركشن مايتونيا زي ما احنا شايفين في الثينر او في التنج او في الاكستنسور ماسلز اوف ذا فور ارم. بالنسبه للاكسترا ماسكولار مانيفستيشن عندنا الاوكيولار مانيفستيشن اللي احنا قلناها في الاول، ان احنا عندنا كاتاركت اللي اونست قبل 50 سنه. في حاجه ثانيه ممكن تحصل، عيان لو عنده بايفيشال ويكنس هيبقى عندي كورنيال ابريجن سبيشالي في تايب 1. الهارت افكشن بيبقى عندي اريثميز بكل انواعها بقى، العيانين دول بيضاي للاسف من اي في بلوك. طيب بيبقى عندنا كمان مشاكل سليب، بيبقى عندنا اوبستراكتيف سليب ابنيا، العيانين دول ممكن يحصل لهم ريسبيراتوري امبارسمنت اب تو تايب 2 ريسبيراتوري فيلير، بيبقى عندهم سنسوري نيورال هيرنج لوس. طبعا كل المانيفستيشن اللي بنقولها دي موجوده في دي ام 1 اكتر بكتير من دي ام 2، سنسوري نيورال هيرنج لوس اكتر في دي ام 1 ومش موجوده في دي ام 2 تقريبا. طيب بعد كده عندنا جي اي مانيفستيشن، سواء upper جي اي مانيفستيشن او lower جي اي مانيفستيشن. الابر ان ذا فورم اوف جيرد ديسفيجيا، الديسفيجيا بتبقى واضحه قوي في الدي ام 2. بيبقى عندنا lower manifestation alternating diarrhea and constipation. وبعد كده غير الجي اي بيبقى عندنا cognitive affection في الدي ام 1 العيانين دول بيبقى عندهم dysexecutive function وبيبقى عندهم او executive dysfunction سوري، والدي ام 2 بيبقى عندهم برضو نفس الاعراض بس less obvious. بعد كده عندنا endocrine system affection في الدي ام 1 هيبقى عندنا insulin resistance، العيانين دول بيبقى عندهم diabetes معظمهم، hypogonadism، thyroid disturbance in the form of hypothyroidism ولو فيتامين دي ليفل. دي ام 2 less obvious بس بيبقى عندهم excessive sweating. طيب الناس الدي ام 1 بالذات بيبقى عندهم increased risk of cancer. فين الاماكن بتاعتها؟ نفس الاماكن بتاعت الاندوكراينوباثي بالظبط، يعني بيبقى عندنا اندوميتريال كارسينوما في الريبرودكتيف تراكت او ثايرويد كانسر او كولوريكتال كانسر. طيب بعد كده في سب تايبس اللي اتكلمنا عنهم في الاول، ان احنا عندنا congenital onset دي ام 1 وعندنا childhood onset دي ام 1. كل اللي فات كان late onset او adult onset. طيب ايه ان بريف كده، ان انا التشايلد هود onset ان انا بيبقى عندي مينلي مشاكل كوجنيتيف، العيانين دول بيبقوا اي دي اتش دي اوتستيك فيتشرز او عندهم ليرنينج ديسابيليتيز، انما الكونجنتال بيبقى عندهم فيلير تو ثرايف وبيبقى عندهم ايه فيدنج ديفيكولتي من الاول. بس معظمهم ممكن لو عدوا مرحله النيونيتال بيريود دي ممكن بعد سنين يقدروا ان هم يبقوا سيلف ديبندنت. الكونجنتال والتشايلد هود ما ننساش ان هم عدد الريبيتس بتاعتهم اكتر بكتير من الايه الادلت اونست. طيب الدايجنوزس لابوراتوري ورك اب مش هتفيدني كتير، سي كي هيبقى مودستلي اليفيتد، الاي ام جي هيبقى كاركترستيكالي عندي فيه الدايف بومبر ساوند اللي بسمعه، واكسنج اند وانينج فينومينا اللي بتظهر مع الدي ام 1 والوانينج بتظهر مع الدي ام 2. ادي المنظر واكسنج اند وانينج اهو، ده في الدي ام 1 والوانينج اللي هو بيبقى لو امبليتيود وفريكونسي عاليه كده في الدي ام 2. طيب الجينيتك كونسلنج فور ذا بيشنت اند فيرست ديجري ريلاتيفز، لان احنا قلنا ان هو اوتوزومال دوميننت، العين دول بقدر ان انا اعمل جينيتك تيستنج في اللوكوسايت بتاعتهم من بلاد سامبل واقدر اشوف احنا عندنا الميوتيشن ده ولا لا، وممكن اعمل الفيرست ديجري ريلاتيفز لو العيانين دول مانيفستنج. طيب according to the treatment بقى، اول حاجه العيان ده عنده مشكله مصل سواء بروجريسيف ويكنس او الى اخره، العيانين دول هيبقوا محتاجين اورثوتكس، لازم اريفير تو فيزيوثيرابيست عشان يقدر يساعدهم، سواء محتاجين ووكر كينز، محتاجين اورثوتكس مثلا انكل فوت اورثوزس او حاجه. المايتونيا بتتحسن على ايه؟ كلنا عارفين ميكسيلتين، بس للاسف هو مش موجود في مصر، في ناس بتجيبه كده يعني من بره، لكن الحاجات اللي احنا بنستخدمها بشكل كبير يعني اللاموتريجين، الفينيتوين، الكربامازيبين والاسيتازولاميد. الدوزج بتاعتهم ده الميكسيلتين، المفروض ان احنا ممكن نوصل اب تو 200 مللي جرام 3 ديفايدد دوزز في الميكسيلتين. اللاموتريجين ممكن نوصل ل 300 مللي جرام. فينيتوين الافريج دوز 100 مللي جرام بير داي. الكربامازيبين 400، والاسيتازولاميد ممكن وانس ديلي. طيب بعد كده احنا ما ننساش حته الدي ام 2، ان احنا قلنا الناس بيبقى عندهم ماسل بين ان اكسس، فتلاقي عينه فايبروميالجيا مش بتحسن على البريجابلين والدولكستين اللي هم الاف دي ابروفد، فساعتها نبدا نفكر ان احنا ندي حاجات من مايتونيك ايجنتس اللي احنا شايفينها السلايد اللي فاتت، هتلاقي العينه ممكن يحصل لها امبروفمنت. طيب من ناحيه الكاردياك افكشن لازم نعمل انيوال فولو اب للاي سي جي. من ناحيه السليب افكشن ندي العيانين دول مودافينيل او ارمودافينيل عشان اكسسيف داي تايم سليبنس، او نعمل لهم باي باب لو محتاجين ريسبيراتوري اسيستنت. وبرده ما ننساش ان العيانين دول لازم ياخدوا الفاكسينز بتاعتهم عشان هم عرضه اكتر ان يحصل لهم تشست انفكشن. بالنسبه للاي مانيفستيشن كاتاراكت هشيله، العيانين دول ممكن اعمل لهم كراتشز معينه عشان قصه التوزس اللي بتبقى موجوده. بناحيه الجي اي سيمبتومز برضو امانج اكوردنجلي. طيب الاندوكراينال سيستم المين ستيت تريتمنت، وانا نعمل يعني عندي مشكله في الهرمون اعمل هرمون ريبليسمنت ثيرابي. طيب ناخد بالنا قوي عيانين مايتونيك ديستروفي تايب 1 وتايب 2 ات فيري هاي ريسك ان يحصل لهم سايد افكتس مع الانستيزيا. الناس دول بيبقى عندهم ديلايد ويننج، فاحنا محتاجين ان احنا ناخد بالنا مع العمليات اللي بيدخلوها during pregnancy. الحالات البريجننت كلهم بيبقى عندهم increased manifestation سواء دي ام 1 او دي ام 2، بس الموضوع ده بينتهي بمجرد الدليفري. برضو ناخد بالنا من نيونيتس بتوع المادرز اللي عندهم دي ام 1 بالذات. النون ديستروفيك مايتونيا بقى هو ايه المانيفستيشنز بتاعتها الكومن؟ ان انا عندي ايبيسودك مانيفستيشن سواء ويكنس بين او عندي مايتونيك سيمبتومز بتلاست من دقائق الى ايام، والعيان ده بيبقى ان بتوين الاتاكس دي بيبقى فيري هيلثي او كومبليتلي هيلثي. طيب احنا عندنا تو تايبس، عندنا صوديوم شانيلوباثي وكلهم بيبقوا اوتوزومال دوميننت، وعندنا كلورايد شانيلوباثي. الصوديوم شانيلوباثي دول نوعين، هايبر كاليميك بيريودك باراليسيس وبارامايتونيا كونجينيتا. الكلورايد شانيلوباثي دول بيبقوا تومسون ديزيز ده اوتوزومال دوميننت، والبيكر تايب بيبقى اوتوزومال ريسيسيف. طيب بالنسبه للصوديوم شانيلوباثي المفروض هنتكلم عن هايبر كاليميك بيريودك باراليسيس ابيسودز زي ما اتفقنا اوف ستيفنس مايتونيا ويكنس، دايما بتيجي مع اكسرسايز بعد ما استريح من اكسرسايز او لو صمت كتير. ممكن تقعد لحد دقائق وبتافكت اللور لمب بيبقى فيها ويكنس، والابر لمبز او الفيس بيبقى فيه عندنا المايتونيك فينومين. البارامايتونيا كونجينيتا بقى هي اسمها بارادوكسيكال مايتونيا. ليه؟ لان احنا زمان قلنا الورم اب فينومينا دي بتحسن المايتونيك سيمبتومز، لكن في العيانين دول العكس، العيان ده لو عمل اكسرسايز هتلاقي حصل له مور ورسننج. طيب بالنسبه للكلورايد شانيلوباثي احنا عندنا التومسون والبيكر الاثنين نفس المانيفستيشن، شبه قوي الدي ام 2، بيبقى عندهم ماسل بينز اول ثرو، وبيبقى عندهم ليد لاج، دي ساين مشهوره قوي عندهم، والسيمبتومز بتاعتنا بتبدا في اللور لمب وبتبدا تاسند ليتر اون اب. التومسون ديزيز زي ما اتفقنا ان هي اوتوزومال دوميننت تظهر ات بيرث، انما البيكر بتظهر في الفيرست او سكند ديكيد. طيب المين ستيت تريتمنت بالنسبه لنا هو الميكسيلتين برضو زي ما اتفقنا قبل كده، هو صوديوم شانل بلوكر. طيب التيك هوم مسج المفروض ان احنا عندنا الديستروفيك مايتونيا عباره عن الترايات زي ما اتفقنا، بروجريسيف ماسل ويكنس، مايتونيك فيتشرز، وعندنا ايلي اونست كاتاراكت. النون ديستروفيك مايتونيا بتبقى عباره عن ايبيسودك اتاكس اوف ماسل ويكنس، وان بتوين العيان بيبقى كومبليتلي نورمال. الميكسيلتين هو تقريبا دراج تشويس اللي موجود او المفروض ان احنا نستخدمه طبعا بجانب الانتي ايبيلابتيك دراجز. والدي ام تيز دلوقتي اون جوينج عشان نقدر نطلع تريتمنت للديستروفيك مايتونيا سبيشالي تايب 1. And finally, thank you.
Thank you for your demystifying lectures and nice presentation. Now, is there any time for discussion, says Dr. Nagi? Okay. Any question for the floor first? No. Okay. لا floor الأول ما احنا بنقول floor بس. No questions. Okay.
دكتورة دعاء، سؤال ليكي بعد اذنك، استفسر بس عن حاجة. هي فين؟ دعاء اخر واحدة. لا ما عنديش اسئلة في الاول. دكتورة دعاء، ما هي مفيش يا عم، مش انت قلت لي؟ لا مش انت قلت لي؟
اتفضل يا دكتور.
يا عم بالنسبة للميكسليتين، انا قريت عنه يعني كونتروفيرشال، هو اصلا بيستخدم في الهارت.
بالظبط، هو انتي اريثميك مينلي.
انتي اريثميك. في ستاديز كتير اتعملت عليه في المايوتونيا، لكن هو اوف ليبل.
هو اوف ليبل، هو مش
الى الان اوف ليبل.
اوف ليبل بالظبط.
وفي ستاديز كتير اتعملت عليه، يعني ما هياش برومسنج. انت بتقولي دراج اوف تشويس.
هو كريزلتس المفروض الميكسليتين، وليتر اون قالوا الناس اللي نون توليربل للميكسليتين ممكن ياخدوا لاموتريجين، يعني شوت برضه effective results.
أنا بس هرد على الدكتور محمود. هو we should prefer to subdivide myotonia into a channelopathy. One of the orders of channelopathies is a chloride channelopathy. Channelopathies is a big spectrum of disorders, including epilepsy, heart, and autism, attention deficit disorders, migraine, as well as muscles and sometimes peripheral nerve disease. So it had another concept of treatment. The drugs involved in the management of channelopathies are mainly anti-epileptic drugs and anti-arrhythmogenic drugs, as well as acetazolamide. So mixelitine is an off-label drug for these acetazolamides. Phenytoin, I think, is better than lamotrigine in management of myotonia, whether it is periodic paramyotonia or myotonia congenita. So this is my concept, that it is a channelopathy rather than a muscle disorder. Thank you.
Yes, you need to, yes.
Welcome.
Welcome.
Assalamu alaikum. Thank you so much. Very nice talks. I wanted to comment on an earlier talk, but since we are talking about myotonias, in my experience, mexpirtine is much more effective than dilantin or phenytoin. I've used it extensively, around 200 milligrams twice a day. It works pretty good. Haven't had any side effects. Patients who, although dilantin is much more widely available, again it's off-label use for myotonia, in younger patients, particularly girls, it has got significant cosmetic side effects, young kids. So that's why I prefer. Although it is effective, it is efficacy is not as strong in my experience as compared to mexilitine. My other comment was on the earlier talk, the ultrasound talk. A wonderful talk, and I would suggest to you guys that, great talk, I would suggest that you use it. You got tons of patients. I see in the earlier day I was there, you're following a lot of patients with congenital diseases, muscular dystrophies. You're also looking at ALS. It's a very powerful tool. When I was doing my training, it had just come around, and I used to wonder why ultrasound, as you said in the first sentence, that why a neurologist is looking at ultrasound. But it's a very powerful technique, and with the new machines coming, we just got hired, one of our residents went for fellowship to Mayo Clinic and came back, and he's starting and after fellowship in ultrasound. It's one of the latest tools we have, very convenient. I would suggest that do some projects in some following these patients. If you have time and you've got a wonderful mentor over here, you should publish. It's a very publishable topic.
I already published, and
yeah, I saw that. I saw, but there are multiple diseases. So what I'm trying to say over here is that it's a new field in the sense that with the new powerful machines, the resolution is much better.
We
And
also
so-
did studies on vagus nerve and its relationship to autonomic disturbances in Guillain-Barré, and also phrenic nerve ultrasound and its relationship to respiratory compromisation besides diaphragmatic ultrasound, but they are ongoing published.
Many
Diaphragmatic
people are
only has
using,
been published.
in interest of time, many people are using nerve conductions in addition, ultrasound in addition to nerve conductions. You collect the data in these patients because it's something which you can see visually. You're talking about a neuropathy, you're talking about a focal neuropathy. It's a very powerful tool in the clinic.
Yes.
Wonderful talk and congratulations.
Thank you very much. معلش, I want to give a big thank to Dr. Ibrahim المنشاوي, the head of our department and our scientist and role model. شكرا جزيلا يا دكتور، حضورك شرفني جدا. حضرتك لا تتوانى عن مساعدة أي حد فينا. شكرا جزيلا.
كويس يا لازم تهني مال في ايه؟ لازم لسه عندنا رئيس القسم يعني، هو في ايه يا ايه؟
لا ده
ماشي يا
حقيقي
ابراهيم،
والله.
عامل لهم
لا لا ده حقيقي.
المهم خلاص يا ايه، خلاص يا
ماشي.
I would like to thank you, but as we know, as the sonography for prognostic on weaning,
Yes.
is there any available sonar in ICU on the patient on mechanical machine? Am I right?
Yes.
On machine. Is it available to do sonar in ICU?
Yes, portable ultrasound machine. I
Yes,
have one.
I think it is because. Thank you, all of you, and we will now move to the second session. And thanks for Dr. Minshawi. Okay. Thank you, all of you.
Bismillah ar-Rahman ar-Rahim. We'll pass to the opening ceremony because we want to be on time. And Professor Dr. Azza Abdel Nasser, Head of Neurology Unit at Ain Shams University, will represent our department because I think Dr. Maha is in, the chairman of our department is another psychiatry conference down. Dr. Fathi Afifi, Professor of Azhar, Professor of Neurology, Azhar University. ممكن تقعدوا. We can sit. هتبتدوا بقى السلام الجمهوري والحاجات بتاعت. اتفضلي يا عز، اقعدي في النص. اتفضلي. محدش جاي. هنعمل عشان في دروع، هندي الاجانب دروع.
لسه القرآن والصلاة.
Can we start? شكرا لكم. دكتورة عزة عبد الناصر, Head of Neurology Unit in Shams University, will have the talk.
بسم الله الرحمن الرحيم. طبعا فخورين بافتتاح الانترناشونال كونفرنس النيوروماسكولار تشابتر للجمعيه المصريه لطب المخ والاعصاب والطب النفسي وجراحه الاعصاب. انا هتكلم الاول on behalf of دكتور هاني عارف, امين الجمعيه المصريه للطب المخ والاعصاب والطب النفسي. لظروف قهريه هو ما عرفش يحضر معانا النهارده, لكن بالنيابه عن الجمعيه احنا بنشيد بالاكتيفيتي اللي الجمعيه بتعملها من المؤتمرات وورش العمل في جميع الشابترز, وده ليه واقع كبير جدا في الفايده اللي بياخدها كل الناس من اكبر حد لاصغر حد من تبادل الخبرات, وكمان فكره ورش العمل والهدف التعليمي القوي منها. النيوروماسكولار تشابتر من الشابترز اللي هي انضمت اخيرا بقت على قائمه الاهتمام بيها بشكل كبير جدا, ودكتوره ناجيه ليها باع طويل وكبير جدا في دعم هذا النشاط, وده بالاضافه للتعاون الكبير مع كل زمايلنا واساتذتنا الافاضل في كل الجامعات المصريه والمراكز البحثيه. أنا بس هتكلم كلمة بسيطة جدا على إن إحنا فخورين إن إحنا المؤتمر النهاردة هو تتويج لرحلة كفاح طويلة ابتديناها بالنسبة لنا من عين شمس, طبعا تحت رعاية أستاذنا الأستاذ دكتور أنور الأتربي, رائد التطوير في اسم طب المخ والأعصاب في طب عين شمس, وكان تكوين معمل المخ العضلات والجينات كان جزء كبير من هذا التطوير. وطبعا هو اختار الدكتوره ناجيه لانها تكون هي البطله اللي تبتدي الطريق الصعب, وبالرغم من كده هي لا كلت ولا ملت, ومن رغم ان هي عارفه انها داخله الطريق اللي كله تحديات, لكن هي ما شاء الله عليها استمرت بنجاح, بالرغم ما كانش فيه الادويه متوفره, بس هي اصرت على ان المرضى دول من حقهم ان هم يكون لهم فرصه. فعملت الريجستريز وعملت لهم التشخيص الدقيق جدا بالتولز المتاحه لينا, وبالتعاون مع المراكز البحثيه وزمايلنا في الجامعات الاخرى. واخيرا بقى في هوب جديد ان احنا عندنا فرصه لعلاج المرضى دول بدعم الدوله, واعتقد ان خلاص بقى دي المكافاه اللي بعد المشوار الطويل. فبشكرك يا دكتوره ناجيه, بشكر لدعم المرضى, بشكر اساتذتنا الافاضل اللي ليهم فضل علينا اللي وصلونا لده النهارده, وبشكر فريقك المجتهد المثابر, وده كان حلم من احلامك ان يكون لك فريق. الفريق ده يكون جيل جديد يكمل الطريق اللي انت ابتديتيه, وان شاء الله يحقق طموحات اكبر ونجاحات اكبر باذن الله. شكرا.
Welcome all of you. It is of my pleasure to be here. Professor Nagia selected me because I am the oldest one. They are the youngest one and I am the oldest one. ودائما زي مجلس الشعب كده بيختاروا في الحفله الافتتاحيه اكبر واحد سن. But I very happy and appreciated this meeting, and we would like to thank Professor Nagia and her team. And before, I think the first one in Shams University was Professor Trebi and Professor Samia Ashur, because she is very hard well. Thanks, Professor Nagia, for your patience and for your effort, and thanks for team, and thanks for Mr. 2000 for this nice presentation. We are hoping in the future a new lectures and a new investigation and research and more coordination with other department of other universities. Thank you indeed, Professor Nagi.
Thank you, Professor Fathi Afifi. We are very delighted this year to be the third international conference of the neuromuscular chapter of our society, Neurology, Psychiatry, and Neurosurgery, in collaboration with the Neuromuscular unit in Shams University. Actually, the neuromuscular branch had a little contribution of some of the professors, but many eminent professors in the Egyptian university started this effort several years ago, and they must be honored today. From these professors, we have 3 eminent professors at Ain Shams University: Professor Samiha Abdelmenem, Professor of Neurology, Professor Anwar Itrebi, and Professor of Neurology, and also Professor Samia Ashur, Professor of Neurology. We have today Professor Samia Ashur with us. Dr. Samia was the first one to study abroad in France, and she studied the nerve and muscle biopsy and electron microscopy of nerve biopsy, and she had many publications, and she supervised many of the research works and doctorate degrees thesis that was done in Egypt. So it's our pleasure today to thank Dr. Samia Ashur for her work in neuromuscular disorder. Please, Dr. Samia. خليكي ماسكة عشان هيقع مني. حضرتك قدم الطبق الجميل بقى. A plate إسهاما، شكر لإسهام بروفيسور سامية في النهوض بأمراض العضلات والأعصاب في مصر، وإن شاء الله هتنهض بالأجيال الجديدة اللي جاية بإذن الله. اتفضلي. تعالي يا عزة.
أنا يعني بشكر كتير دكتورة ناجية للتكريم يعني اللي هي عاملاه النهارده لشخص يعني. طبعا هي يعني اشتغلت معايا كتير، ويعني كنت مشرفة على الرسالة بتاعتها. يعني اللي جمعنا أكتر إن إحنا صحيح أعضاء في هيئة التدريس في الاسم واحد، لكن اللي جمعنا أكتر إن إحنا بنشتغل في يعني في دومين واحد اللي هو المسل اند نيرف ديزيز. فكان يعني الاهتمام ده هو بالجهه ديت هو اللي جمعنا اكتر من اي حاجه تانية. يعني انا بشكر ناجيه وبهنيها طبعا على مشوارها الطويل في يعني متابعه وتشخيص وعلاج الامراض العضلات اللي هي كانت بالنسبه لنا يعني احنا يعني بصراحه يعني كل واحد فينا لما كان يدخل له في العياده حاجه فيها ماسل ديزيز كان يبقى يعني مش مبسوط. يعني هو عارف ان هو هيقعد يشخصها ويحطها على الرف. في الحقيقه ناجيه يعني اسهمت يعني او عملت جهد كبير في الحقيقه انها تجيب الحالات اللي احنا ركناها على الرف وتشتغل عليها ويبقى ليها مردود كويس، وان شاء الله ربنا يوفقها في هذا المجال وفي غيره يعني. بس هو في المجال ده كان مهم جدا انها يعني اشتغلت فيه، وربنا يوفقها ان شاء الله.
ألف شكر. خليكي معانا بقى عشان عزة. We are happy that we started to have many neuromuscular units in the Egyptian university. We started with the neuromuscular unit in Shams University, but now we have another neuromuscular unit in Nasser Institute Hospital, one of the main insurance hospitals in Egypt. And also we have in Alexandria University, Tanta University, Mansoura University, Asyut University, and I think that Zagazig University and Aswan. I hope that you will upgrade your units, but all the services needed to help diagnosis of neuromuscular disorders. I was happy about the work of neurophysiological studies in many universities, and now the ultrasonic of diaphragmatic muscles and ultrasonic of muscle and nerves is very good. I want to thank Professor Hani Arif, who helped the neuromuscular unit in Shams University to upgrade, but unfortunately he is not with us. But also we have Dr. Azza Abdel Nasser, our director of neurology department, also still supporting our neuromuscular unit. We are trying to have another center in Children's University Specialized Hospital. So thank you, Dr. Azza. Also, we are honored to have an international professors who came from long distance and take from their tight times to help us. We will start with Professor Albert Ludolf, Professor of Neurology, Ulm University, Germany. Professor Ludolf now, for several years, he insisted to come in his very tight time to teach us. Yesterday, he showed us the approach of diagnostic approach of ALS. Now, after a few minutes, we will have the new therapies of ALS and the hope for ALS patients. Also, Professor Ulm is sharing in research through German University of Cairo. He is trying to establish a neurodegenerative center and to help the diagnosis and therapy of ALS in Egypt. So thanks, Professor Ludolf. Thank you so much. Thank you. Take care. For the first time, we have in Egypt Professor Zaim Siddiqui, Professor of Neurology, Alberta University, Canada. Professor Zaim Siddiqui has a main research in myasthenic disorders, especially myasthenia gravis, immune-mediated myasthenia gravis. Also, he's an eminent professor in neurophysiological studies and has many courses, I think, in the American Academy of Neurology to teach the neurophysiology. And there was, by destiny, God, Allah, helped that he will, through one of our friends, Dr. Mohammed Fouad in Saudi German Hospital, Riyadh, Medina, something happened that he led us to new Professor Zaim Siddiqui and to invite him to have his first neuromuscular workshop in Egypt. He came from Canada to have the course, and he gave us a very, very beautiful and fruitful and very, very course full of information. We learned a lot. We learned a lot from you. Thank you so much. Thank you. Thank you. Thank you. Yes, please.
Thank you so much. So, in fact, I learned a lot coming here. And it's so heartwarming to see so many young women in your department, dynamic girls, dynamic and full of enthusiasm. They really want to learn. And you guys are lucky to have such a motherly figure over here. It was really heartwarming, and I felt really, how should I say, it's very impressive and something very personal. Thanks for having me over here. It was a pleasure, and not only a pleasure, but a learning experience for me as well. All the best to you. It's a wonderful, wonderful department, unit, collegial, and you got some real firebrands, young girls and women coming up. I see in the next 5 to 10 years, you will have a trained, and you gave me a reason why, and I'm, but it was really, really heartwarming. So again, thank you so much for having me here, and my wife, of course. On Lubna's behalf, I want to thank you. Thank you so much from my heart. Thank you.
Thank you, Professor Zaimi. Thank you, Professor Fathi Afifi, Professor Azza Abdel Nasser, Professor Sami Ashur. And I think it's time to start the plenary session. We have 2 nice lectures. We are waiting to hear our professors. Thank you so much.
Can I?
بسم الله الرحمن الرحيم. هنفتتح السيشن تعتبر السكند سيشن. طبعا انا اللي يشرفني ويسعدني ان احضر مؤتمر النيورو ماسكولار مع بنتي وتلميذتي وكل يعني مهما قلت فيها انسانه مثابره ما بتملش ولا عندها حاجه مستحيل نهائي. من ساعه ما حطوها في الاول لوحدها خالص في الماسكولار ماسل ديزيزز وهي الحقيقه فيري انترستد انها توصل للنهايه مهما كانت النهايه. انا مش يعني مهما قلت الواحد بيفرح جدا لما بيشوف حد بالمثابره ديت والجهد اللي بيتعمل، وبعدين عمالين نسمع عنها في الاخبار وفي التلفزيون وفي كل مكان عن كل النجاحات اللي حققتها في كل مجال دخلت فيه. فربنا يوفقها ودايما يا رب تبقى في الخير ونسمع عنها كل خير، وان شاء الله مؤتمر ناجح لأن اللي قامت عليه والمجهود اللي عملته أستاذة عظيمة وفريق ربنا يحميه ويبارك فيهم ويخليهم دايما نصرة لكل المرضى اللي بيعانوا واللي هم حاولوا يلاقوا لهم حل ويلاقوا لهم أدوية جديدة الحمد لله. أول محاضرة في السيشن دي بروفيسور ألبرتو لوندلوف University, Germinal University. He will speak on update of amyotrophic lateral sclerosis. Please.
Yes. Thank you very much again for your overwhelming hospitality. This time and previous times, I'm glad to be here, and I hopefully will be part of the success of this very nice conference. What I decided to do today, after I gave a talk on the developments in neuropathology and diagnostic criteria of ALS yesterday, I wanted to discuss with you therapeutic developments. And this is, of course, something which is by itself very good news, because if you have a talk of 30 minutes on therapeutic developments for such a disease like ALS, of which Charcot already said that therapeutics will be far in the future, will be only possible far in the future, this is good news. In the first step, I just want to repeat with 2 slides what I said yesterday to give you a basis, and then I will talk on non-pharmacological treatment attempts, pharmacological treatments with conventional drugs, but also with the heavily discussed antisense oligonucleotides. So I told you yesterday that ALS is, of course, a motor neuron disease. It consists of progressive motor paresis, and it includes upper and lower motor neuron deficits in most patients. And I also told you that modern use of the clinical pictures mirror the recent neuropathological findings that disease has a focal begin, it spreads continuously, and finally generalizes in a pattern of paresis, a monosynaptic pattern mirroring the connectome of humans. Of course, the patient dies after 2 to 4 years, and he or she dies by respiratory insufficiency, and he or she is unable to communicate. And it is called a rare disease. In our country, we have an incidence, a yearly incidence of 3 per 100,000, which results in a not so rare or seemingly not so rare event to get the disease. The lifetime risk is bigger than 1 to 400 in our country. And I also told you that in my view, the major advance, where is the pointer? No. Where is the pointer? Yeah. No? Okay, I can explain like this. I just told you yesterday that in my view, the major advance in the field, one of the major advances was the definition of the neuropathology and the longitudinal definition of the pathology of ALS by Professor Heiko Brag, who showed us that the disease spreads along the association fibers, into cortical fields, in particular in the frontal fields, but also into the sensory association fields. And if it catches, the process catches neuronal populations which are monosynaptically connected with subcortical nuclei, like the alpha motor neurons, like the inferior olive, like the red nucleus, like the dorsal striatum, then these neurons get also affected. So let us get to treatment. And of course, since the antibiotic area, in my view, since 70 years, therapy is connected with drugs. But there's also non-pharmacological treatment, and this is something, in my view, important in ALS. As you see on this graph, I need a pointer. Would be nice. No, doesn't work. Okay. It's better to explain. Yeah. You see these curves. These are curves of patients with different BMIs. This is one of 20 studies. It has been several times reproduced. This is our population, our clinical population. And you see that of those who have a BMI lower than 23 have died after 1.5 years, 51%. But with a BMI of larger than 25, only 34% have died. It's a big an important and established prognostic factor. But there could be many arguments how this could be explained. No, it doesn't move. There are many arguments how this could be explained. And we tried to resolve this. We wanted to ask ourselves whether an anti-catabolic interventions, which keeps the weight normal or normalizes the weight, is useful for the patient. And in Germany, we did a large trial with 200 patients, and the intervention was a fat-rich food supplement. 100% fat, it tastes bad. And it's about 400 kilocalories per day plus. We tested it versus placebo, a randomized, double-blind, placebo-controlled intervention period, 1.5 years, and it was funded by the German government. And we saw that the intervention did not work statistically significantly in all patients. The p-value was 0.9%, which is of course not the limit which the statisticians want from us. But if we look at the fast progressing patients, the p-value was much better, and the curves can be easily distinguished. The survival curves can be easily distinguished. If we look again at the fast progressors, they really have a clear-cut effect on survival. I have to tell you that the taste of the supplement was so bad that 25% of the patients refused to take the intervention. And if we excluded these patients, the effect of the intervention was even much better. It was also very consistent that the decrease of the conventional score for ALS, ALS-FRS, was positive in all patients. It was slowed down in the fast progressors and the slow progressors. And if we looked at the biomarker, neurofilaments, I told you yesterday, it's a prognostic and diagnostic biomarker. And if we try to look at the data, we readily saw that the placebo patients showed an increase of NFL during the disease course, during 1.5 years of observation, but the patients with the intervention had a decreased neurofilaments, representing, of course, axonal integrity. And also we showed that those patients who could keep their body weight, it is shown here, This is the BMI change in the verum, and this is the placebo group. The placebo group lost a BMI per month of 0.28, the verum only 0.1, so even the dosage was not good enough, but it was better, it worked. The p-value was significant. We say that this is meant to be target validation. So we conclude from our study, of course, survival is a challenging endpoint in slow progressors, and therefore the primary endpoint, survival for the entire group, was not sufficient statistically. However, the positive effect on survival of fast progressors and the ALS-FRS of all patients was clearly visible and could be demonstrated. We had an effect on biomarkers of the intervention group, and we showed positive target validation. We are always asked, what are you telling your patients? We are rather uncertain. We know that weight stabilization has an effect, I showed you, but we do not know, for example, know whether carbohydrates or protein or lipids are better. We just give our patients the advice, keep your body weight. And we are doing a next trial by being with a more sophisticated design as this first trial, which is also financed by our government, a confirmatory trial which recruits in January 2023. I want to take a sidestep on this. I didn't mention to you that unlike Parkinson's and Alzheimer's disease, the preclinical period of ALS was not defined by Professor Brach in ALS, and therefore we do not know much about the preclinical period in ALS, and therefore we did a case control study in Germany and looked at cases and controls and looked at the development of body weight during life in people in Germany. On average, a typical German gains 10 kilo between 20 and 60. This is the same, by the way, in Sweden. I don't know about Egypt. But if you look at ALS patients, they do not gain that much, and their weight gain flattens about 15 years before onset. This is, in the beginning I didn't believe it, or it was hard to believe for me. But our Swedish colleagues did a similar study, Professor Fang, and saw the same. So we believe that the weight development is a candidate for a preclinical period of ALS, 10, 15 years earlier. And more so, these are unpublished data, we have a cohort of preclinical gene carriers. And we looked at their body BMI, we looked at their triglycerides and their HDL and LDL profile. We compared the benign SOD cases, which have a life expectancy when they get the disease of 7 to 8 years, with the less benign C9orf mutation carriers. And we saw that those patients who have the worst disease, C9orf, have a better lipid profile, higher HDL, lower triglycerides, lower BMI. So just the opposite what we teach the patient in internal medicine, and of course consistent with the recent finding, a candidate for a pre-symptomatic period and perhaps for prevention. I come back to that. I also told you yesterday that one of the very efficient ways to treat ALS patients is non-invasive ventilation. We heard yesterday from one of our colleagues that the indication is associated with increased CO2 hypercapnia, and the patient yesterday told us that if you treat these patients, they have a symptomatic improvement bad sleep gets immediately good, morning headache disappears, and cognitive performance gets better. Of course, this is also associated with increased survival. In this group of patients, thoracic onset, it is about 3 to 4 years in our hands and our statistics. So these are the non-pharmacological treatments. They are efficient. Remember the numbers, 1.5 years for the BMI. And here also the same amount of months, extra months, which we give to the patient. Now I discussed drugs. I can tell you about 3 drugs which are heavily discussed. The first one is edaravone. Edaravone, as you know, was shown by a Japanese group to be effective on function, not on survival, in a small subgroup of ALS patients. In Germany, of course, the patient requested it, and our health authorities wanted us to document the effects of this financial effort, like we did, by the way, in nusinersen in adults and adolescents. In nusinersen, it was positive, it worked, but here, I have to tell you, we did an observational study of edaravone in Germany, and we could not show an effect of intravenous edaravone. It was published in JAMA Neurology earlier this year, and this is not only true for the entire group, it's also true for the small subgroup which led to the introduction of edaravone into the US market by FDA and also to Switzerland. And of course, we should not, this is not the final word, we should not give up, and of course, we do not give up. There are 2 studies with oral edaravone at the present time. The first one is done by FERA International. The study is called ADORE, and it's randomized, double-blind, placebo-controlled, and we will know later next year. And the other one is done by Mitsubishi Tanabe, who also compares edaravone with design in the control group of edaravone plus a break of edaravone, 14 days edaravone, and followed by placebo. So we will know with oral drug, with the oral drug, and that will hopefully solve this challenge. Razagilin. We did this in Germany 5 years ago, or 4 years ago, and we did not see in the beginning nothing on survival. Again, the primary endpoint was survival, no significant difference, but the curves differed. This is placebo, and this is razagilin. The patients survived better, but the curves differed very much in the beginning. And therefore we thought that perhaps this difference might be due to the death occurring during the observation period. Meaning in this, after 6 months, there are more fast patients because otherwise they have died after 9 or 12 months. And therefore we analyzed it again, the faster progressors against the slower progressors, and again, razagilin had a clear-cut effect on survival after 6 to 12 months on fast progressing patients. And the same was true on function. It was really remarkable. It was better than we saw this as it was demonstrated in edaravone and riluzole, if you can compare this. And therefore, the conclusion of this razagilin study is that first, the progression rate of the disease influences the outcome of an interventional study, like in the high-fat diet. And secondly, we clearly showed therapeutic effects in fast progressors, and we need a repetition of this study to decide whether this is efficient in all ALS patients. This is a study which was published about 2 years ago in the New England Journal of Medicine. It's a combination of 2 drugs, phenylbutyrate and taurazodiol. The result was slightly positive with a p-value of 0.034, and was heavily discussed, this drug, but I think those who discussed it did not read the last sentence of the study. The authors were cautious. They said in their last sentence, our result must be confirmed in a second study. And this is currently being done. In Europe, we have studied, the inclusion period has been finished. The compound taurosodiol, not the combination, the so-called TUTCA study, and we will have the results in August next year. And there is another confirmatory study of the combination going on, and we also are part of it, and we will have the result later next year. This was also formally positive, clear. So now I get to the heavily discussed antisense nucleotides in ALS. Of course, you also all saw the impressive pictures of the children under nusinersen or Zolgensma, and many people set their hope on this principle. Many people also do not recognize that SMA is a different problem than ALS. In ALS, we know dominant genes. We have to suppress, we have to reduce the toxic function of the protein. So, in SMA, we have to increase the protein levels. And therefore, this is a very different approach, but of course, it was tried within the tofersen trial. And to give you an overview on our country's situation on the genetic level, just as an introduction, SOD1 is the second most mutation in Germany. 15% of the familial cases, 5% are familial in our register, and 15% is also, it's interesting, but of course not the majority of ALS patients. We later talk on FUS, 5% in our country. So this is the first study, the phase 1 study, and it was clearly shown that the development of tofersen is promising. Only slight side effects, dose-dependent plasma concentrations, CSF concentrations increased but non-linearly, and the SOD concentration, like we wanted this, got decreased in a dose-dependent manner. So let's get on to the second or third, the phase 2 or phase 3 study. But before this, the authors, it was published in the New England Journal 2 years ago, did a small or slight glimpse at function, 3 months only, after 3 months only, and they saw that clinical function stabilized under these treatments, respiratory function, and even muscle strength, in which measurement I don't believe personally that much. But it all stabilized, and there was a lot of enthusiasm. And therefore, they, of course, developed a new study design, and they did it in a way which I already explained to you. They distinguished between fast and slow progressors. This is the slope of the functional scale. It was in a faster progressing group about 1.5 to 1.7, and whereas in the slower progressive group it was about 0.3. The plasma NFL levels were about 150 or 130 in the faster progressing, and about 30 to 40 in the slow progressors. So they already learned their lesson from the trials that I introduced to you. Now let's look at the results of this study, which are not published yet, but will be published soon. These are the slower progressing patients, blue ones, and the red ones are the fast progressors. And you see that the curves differs, blues and red ones, and always in favor of the interventional drug, but the results were not statistically significant. It was a disappointment. However, it went into the right direction. If we look at the neurofilament levels, again a marker, it was quite different. You see here in the dotted lines the neurofilaments in the placebo group, and in the blue and red ones are the neurofilaments under treatment. And you see that in the faster progressive group, the neurofilaments went down statistically significantly, whereas in the slower progressive groups, they got into the right direction. So, mixed results. So, we await the paper with interest. It will be published in a few weeks, and we have a step forward, but it is not that convincing as we hoped for. As a comment on these results, I will show you results that we received here in Egypt together with Professor Nakia Fahmy and Nabila Hamdi. You remember perhaps that in the published studies, the SOD levels were reduced by 37% by ASOs. There was a report on a 6-month-old child from Afghanistan by Peter Anderson in 2019, which had a truncating mutation and developed ALS as early as after half a year. So this boy had no SOD level. So the first conclusion is it might not always be good to have low SOD levels, like we do it with the ASOs. We found 2 patients here in Egypt with a recessive trait, which also had greatly reduced SOD activity, meaning a loss of function, which warns us that we should not reduce the SOD levels too much in these attempts to treat SOD patients. So the future is good, but not without complications. This is something which I want to tell you in the end. You know, the development of antisense oligonucleotides is associated with a lot of hope since SMA. This is a 14-year-old patient which they showed to us, 14 years old, ALS in Germany, very uncommon, perhaps more common in your country, but typical aggressive ALS, and she carried a FUS mutation at the position 50-5, which is known to be very aggressive, and she acquired it. It was not present in her parents. We know these patients. We have published 25 of them. They are young, and it's a very sad story. They die 1.5 years later. But there are ASOs for FUS on the way, but only phase 1 studies. The only available drugs in the world are not produced after good manufacturing practice. They cannot be applied in Germany because parents, of course, asked me, can we get these ASOs? I said, I will be in jail if I do this. Then she was treated in the US. The FDA permitted a non-GMP drug, which is given by Dr. Neil Schneider at Columbia University. 1 year later, she deteriorated. She got ventilated, even was reanimated. Was then brought to Switzerland. In Switzerland, they also had a permission to treat this non-GMP drug, or to use this non-GMP drug in this patient, and she improved. She improved. And now our patients of course, request in Germany, because this story is known among the FUS gene carriers, whether we should give public access to this non-GMP drug in Germany. The major weekly newspapers, Der Spiegel, Der Stern, perhaps some of you have heard of this, is leading this discussion, and it is very difficult. So you see, we are on a way of, are on the pathway to ALS therapy. We are in a time of transition, but we have to keep our motivation high for patients like this, clear, but I think we should also care as academic people or academics we should care for keeping standards and quality, and that is something which is not the same. For me, the definite future is early treatment. It is not only stroke, in which we have to say time is brain. This is a patient which is in early stage, only paralysis of the left foot. We included this patient into the ASO studies for SOD. We do watchful care of the SOD families, and we prepare them for trial. I only need 1 minute or 30 seconds for the final slides. So we diagnose very early. Our time to diagnosis is about 6 months in sporadic patients, and we care with the study nurse for all the families in Germany. We have more than 500 families. So what did I want to tell you? We are on the way to therapeutics in ALS. Please don't forget, don't only think about pharmaceuticals. Non-invasive ventilation and anti-catabolic diets have clear effects. Of course, details need to be worked out. We have difficult or early results in edaravone, razagiline, and tutga-butyric acid. It's promising. We are doing studies in which we confirm or refute the findings. And I think the SOD experience is promising. One has to work more on this, but I think they work. And there are already anecdotes on effects on ASOs against FUS. The future is not the expensive drugs. They are transitory in my thinking. The future is prevention, and that is, I think, possible in 10 or 15 years. Thank you.
Thank you, Professor Ludol, for this very nice and informative lecture. And we started to know that now there is a genetic intervention for some mutations for ALS, the SOD1 mutation, the FUS mutation. And because we started a genetic study of our ALS patient, as already you know, and under supervision, we found that SOD1 in Egypt, many families are autosomal recessive. So this means that this tofersen clinical trial, the anti-SOD1, the antisense oligonucleotides to SOD1 gene is not applicable to our patients?
Yeah, I think our finding is extremely interesting. Of course, it needs to be confirmed by more observations like this. But if this is true, then there are two strategic approaches to SOD mutations. First, for the sick allele, the mutated allele, you have to decrease the toxic effect, but also to the healthy allele or recessive mutations, you have to increase the SOD levels. So I think the therapy of the future will have to think about both options to influence gene expression.
I think we can open few questions here before we still have time before Professor Zaim. Yes, please, Dr. Ahmed.
Thank you, sir, for your elaborate lecture. I just want to ask about your experience. Do you have a paradoxical increase in respiratory failure with Doravon?
With edaravone?
Yes.
Yeah, again, we were forced to look at our patients in Germany with the ALS network, and we got no results which were supportive of the evidence that this drug works. But I think we should not jump to conclusions. Wait for the trials with the oral drug, and then we know better. Observational studies are, of course, biased. We need placebo-controlled, prospective, randomized studies to prove it. But this result had the effect in Germany that nobody pays for edaravone anymore. This is opposite to nusinersen. We did also an observational study in which we showed an effect. Our health insurance companies like this at the present time. But I think it's useful.
Okay, thank you.
We have another question. Thank you, Professor Ludolf, for the interesting lecture. I want to ask you about if there is still a role of Rilotec in management of or treating the bulbar symptoms in ALS? Riluzole.
Yeah, riluzole. I mean, riluzole was the first drug. We did not understand anything about the effect. I think there were 3 studies which confirmed the riluzole effect, which were not published by other pharmaceutical companies, which I know of, and it was always a small effect. There are 2 issues which confirm in the, other than the 3 confirmatory studies which were not published, the effect of riluzole. First, that Bragg showed that the affected structures in ALS are all glutamatergic. It's a glutamate release blocker, so it has at least a mechanistic aspect now, or mechanistic foundation. And also, you know, in this first trial, I was part of it. We included each and every patient, late patients. In the end, we saw that these patients had, on average, 1 year survival. Only 1 year survival, late patients. And then we saw that the gain on life expectancy was about 3 to 4 months. Everybody talks about 3 to 4 months, but nobody talks about the average life expectancy of these patients in this trial, 12 months. You have to see this. We now learned that the earlier we treat with riluzole, the better it is. We had false expectations. We didn't know what we were doing retrospectively.
So riluzole can affect or improve the function, but doesn't improve the survival?
No, survival was probed and it improved survival. Nobody showed that riluzole had influence on function, but we had no good scores at that time. ALS-FRS was not present. It was published in 1999 by Cederbaum, and therefore nobody measured function in riluzole. It's still not clear, 25 years later.
Thank you, Professor Lodolf. Now we shift to the next lecture by our eminent figure in neuromuscular disorders, especially in neuromuscular junction disorders, Professor Zaim Sadiq, Professor of Neurology in Alberta University, Canada.
This is on. You need the mic, or you need
The topic will be updates in myasthenia gravis.
the next previous and the laser. Yes, it's fine. Let me start.
Give me 35 minutes. hear me at the back? Once again, thank you for having me. I'll be talking about myasthenia gravis. It's an extremely exciting time in my field, in myasthenia, because lots of new stuff is happening, and I want to share some of the newer therapies which have come around just in the last 5 years. These are my disclosures. This is where I come from, just to orientate you. This is the Western Canada, British Columbia. The US border is down over here. I come from Alberta, Edmonton. Our catchment area is quite big. We see patients all the way up north. These are the Arctics up there. I've got myasthenia patients up in the Arctics, near the Arctics. Gluktuk is it's about close to 2,000 miles. For me, it's extremely important for with these patients who are far off to be able to assess them quickly and manage them effectively. And sometimes we have to use treatments and strategies which may not be used elsewhere. We are the highest center in Canada. So if you look at the nearest academic center or large center is Calgary, which is about 200 miles south. We also see patients from adjacent provinces, British Columbia as well as Saskatchewan, so we're a very large catchment area. Let's talk about some of the, so I'll be talking today about some of the immunopathology of myasthenia as it relates to the new agents. And then I'll be giving you an update on some of these therapies, how they relate. These are very targeted therapies. They target a particular point in this immune pathway. As you know, myasthenia is a prototype autoimmune disease. It's caused by various antibodies, the most common one being acetylcholine antibodies against the acetylcholine receptor, but also the LRP4 and anti-MuSK antibodies, lately agrin, and there's some other antibodies which are being described. The main damage in myasthenia takes a particular course. The antibodies cover the junction, so they don't allow the acetylcholine to interact with its receptor. That's one mechanism. They cross-link the receptors, and they cause destruction of the receptors. Now, this destruction of receptors is caused by the membrane attack complex, and that's critical to know. That's a common pathway which causes the most damage, and then the membranes become simplified and lose their receptors. So the membrane attack complex is the terminal complex of the complement pathway, and we'll talk about that. I shared the slide to prepare you for the new agents, at what point they work. Here are the conventional treatments, which are still, this is a very old continuum. For about 10 years, we didn't have any other treatments. And still, if you look at these medications, they are still being widely used. We are not very far off from these medications. We still have the first line therapies. The second line, we use them commonly as steroid-sparing agents. In myasthenia, typically, we start them most commonly on steroids, lower the dose of steroids, and then add a steroid-sparing agent, which is the common method we treat myasthenia across the world. There are third line therapies, and then the fourth line. So we're still not very far off from these treatments which were been there for many, many years. But that has recently changed in the last 5 years, at least in North America. These drugs which you've been using, they've got some disadvantages. The effect of these drugs is very generalized. They are not targeted. So corticosteroids have got a very wide mechanism of action. And naturally, when you've got non-targeted therapies, you have more chance to have adverse effects. Same for the other agents, azathioprine, mycophenolate, methotrexate, they work in multiple pathways, and so on and so forth. IVIG, one of the most effective agents for myasthenia, again have got very widespread immunologic effects. But these therapies are still the cornerstone. Why? Because they are time tested. We have had them for the last 30, 40 years. They are cheap, and of course they are widely available across the world. But they are associated with significant downsides. Most of them take several months to work apart from steroids. All of the drugs I showed you, almost all, take several months to kick in. They've got significant adverse effects, and some of them increase the chance of malignancy, particularly azathioprine. And in best case scenario, only 75 to 80% patients are responsive. 20 to 25% are still refractory to these treatments. Let's talk about now some advancements which have happened in the last few years. I was talking to Professor Maggie yesterday, and I mentioned about subcutaneous immunoglobulin. I told you I live in an area where we've got patients from long distance. IVIG is a well-recognized therapy for myasthenia for decades, but it has some issues. The patient has come to, at least in Canada, we can only give it in the hospital. The patient has to come to the infusion rooms. IVIG has got significant adverse effects. Headache is a very common one. So about 10 years ago, I realized that immunoglobulins can be given under the skin in several conditions. For example, patients who got primary immune deficiency, they commonly take immunoglobulin on a monthly basis under the skin. So at that time, about 10 years ago, I realized that we can maybe be able to use it in myasthenia as well. So I conducted a trial giving IVIG immunoglobulin subcutaneously. First ever trial in myasthenia of subcutaneous immunoglobulin. These are patients who were had moderately severe myasthenia. They were not in crisis in any way, because giving subcutaneous immunoglobulin means it's a longer infusion, longer time. You can only give that much immunoglobulin under the skin. So if you want to give 2 grams per kilogram, which is the usual dose, you can only give that. That would take you several days to weeks, because under the skin, you can only give that much. At that time, there was no guidelines for dosing of SCIG or SCIG for neuromuscular diseases. It took us a long time to figure the dosing out, and we did that. We used, at that time, only one brand was available, 20% subcutaneous. Regular IVIG is 10%. The SCIG is 20%, anywhere from 15 to 20%. It's much more concentrated. We used a weight-based dosing, and we were able to give 2 grams per kilogram over a 3 to 4 week period very safely. Almost every patient tolerated it well. There were no dropouts. And this was the first time we showed that you can give the whole dose under the skin in these patients. The results were very impressive. Without going into the detail, these are the outcome measures, various. QMG, quantitative myasthenia score, manual muscle testing score, activities of daily living, and the MG composite all showed significant reduction over the study period over 6 weeks. We also measured the serum immunoglobulin concentration, and as the patient improved, you can see the IgG levels increase in the serum. And subsequently, based on the positive results of the trial, we started the first program, SCIG program in the country, and now it's being commonly used across the country. We train other centers. We now have close to, about 50 patients we have prescribed. There were few dropouts. Currently, as of last night, we have 45 patients on SCIG. from various diseases. Almost all of the patients who are on IVIG therapy, maintenance therapy, they go on subcutaneous immunoglobulin. It's much more well tolerated, the patient like it, they get it at their homes. It takes 1 or 2 sessions to train them to give it under the skin. It's given through an automated cylinder, so they are watching television or whatever at their home and they take it themselves, and they really like it. So it has cut down the infusion room visits as well. And more importantly, which I want to show you is this one. One of the things I was concerned was IVIG is expensive, whether they will require more dose, because one of the downside is if you give them under skin, whether they get absorbed or not. And and this is the results we just analyzed yesterday, I call, and most of our patients they were switched from IVIG to SCIG. They have maintained the dose. In fact, in about 13% we have reduced the dose. So 90% of patients are on the same dose as IVIG or less than IVIG. So it's a very effective therapy, well tolerated, and no more cost than IVIG. In fact, it saves the cost of the infusion rooms. There are now a number of brands available, as you can see over here. I told you that from 16% to about 20%. There's a very a novel way of infusing IVIG under the skin. This agent, they give hyaluronidase, which increases the absorption of the immunoglobulin from the skin. So many drug companies have jumped in now because this is the future of IVIG. What we foresee is that chronic IVIG therapy will be only in very few patients. We expect most patients will switch to SCIG in the future. Now switching gears to targeted therapies in myasthenia. So I'm going to talk about these therapies today. As I mentioned, that myasthenia is an autoimmune disease caused by the antibodies produced by activated B cells. The B cells turn into plasmablasts, and those plasmablasts secrete the antibodies. So neurotherapies are either directed against the B cells or complement inhibitors. I mentioned to you the MAC complex. And the third line of therapy is anti-neonatal Fc receptor. These are the most exciting ones, and I'll share them with you. The mechanism of action and the new drugs which have come around. The B-cell directed therapies, again, we took the lead in that. And rituximab, I don't know whether, people use rituximab over here? Okay. In myasthenia?
Yes,
okay. Yes. So this is an early study we published back this is a review. We published our first study in 2017 on rituximab, and rituximab is a very specific B cell, causes B cell lysis. Those B cells which carry the CD20 marker are targeted, and it rapidly reduces the level of these B cells. It's long lasting, several months to sometimes few years. Used for a number of autoimmune diseases, and because of its specific action on reducing the level of immunoglobulins, we started using rituximab cautiously back about 6-7 years ago. And myasthenia, this one was at that time, in 2018, 17, this was one of the largest prospective case series on 22, and we used it in refractory patients. It's an expensive medication, so we could only use it in refractory patients. The government would only give it under circumstances where the patient had tried other medications. So this was used in refractory patients who had tried 1 or 2 other medications. We use it in anti-musk as well. And there was a significant improvement in all groups, particularly in anti-musk patients. So it's extremely effective for anti-musk patients, but also for seropositive acetylcholine receptor antibody patients. The advantage of this is it brings a long-term remission, meaning you have to most of our patients are getting once a year or less than that, about 9 months to a year infusions. So the only disadvantage we find there too, one is they need vaccination against meningococcal, they need a meningococcal vaccine. The other is the cost. It's a little more expensive than other agents, but results are across the board very positive. The only trial that has been done in rituximab and myasthenia is this one. This was done by the Yale group. There were significant issues with the trial. They had about 25 patients in the active arm, and their primary outcome measure was to look at the prednisone dose reduction. The trial came out negative, and there were significant issues pointed out because the patient population had mild disease. So it's hard to show effect of the drug in a milder group of patients. This was followed by this study, which is now recently published, one of the largest studies in rituximab. And what they show is at that low dose, 500 milligrams every 6 months, which is a small dose, both in early or in late disease, most patients show significant benefit. Time to remission. Remission means, in myasthenia, remission means that they've got no or minimal symptoms. Minimal symptoms or minimal disability is called remission. The time to remission was 7 months. Within 7 months, these patients become symptom-free or minimal symptoms. Even in refractory patients, 16 months, they become to go remission. Very high response, 70% as compared to the conventional therapies, about 35%. And the rate of discontinuation, meaning adverse effects, and patient discontinued drug is very low. Just 3% patients discontinued the medication as compared to the conventional therapies. So significant advancement in the therapeutics of myasthenia with rituximab. So you're already using it over here. It is extremely effective drug in myasthenia, in my opinion, with fewer side effects. Cost is a challenge, but in the long term, I see that this would be maybe the first line therapy. In fact, in certain group of patients, particularly in anti-MuSK patients, we give it as a first line. Moving on to complement inhibitors. Again, coming back to the MAC complex. This is the key final common pathway where all the complements come together and cause destruction of the cell membrane. There are a number of therapies that are coming. The major path, this is a complement pathway, just to show you, the main critical rate limit step is conversion of complement C5 to C5 and 5B. The 5B then activates the complement cascade, C6, 7, complement 7 and 8, and forms the membrane attack complex. This is the key step, and most drugs in this are inhibiting this step, conversion of C5 to its active form. There are quite a few agents. The main one is eculizumab. This is the landmark trial in eculizumab. In 2017, it was published, we were part of it. This was conducted now, you have to understand, this was conducted not in regular patients, but refractory patients. Patients who had refractory disease duration of 9 years, chronic myasthenia, and had already tried 3 or more immunosuppressive therapies. So the most severe myasthenics you can think of. So a large trial comparatively in myasthenia. Myasthenia trials are very hard to conduct. It's a rare disease, and because of many reasons. 170 patients assessed and 126 randomized. It is quite a large trial. I'm just going to briefly show you the results of that. That is the REGAIN trial, which I was showing. Then they followed it up with an open label phase, MG302. In the REGAIN, the double blind phase, what they showed was the red is the placebo, blue is the active arm. These patients scored improved rapidly, you can see within the first few weeks. And in the open label phase, the placebo arm also followed. When they switched to the active drug, they showed the same. And this benefit was maintained over the open label phase, which was 2 weeks, was a whole year. This was the summary. Although the primary outcome measure was the MGADL, which is the activity of daily living score, it didn't meet that, but all of the outcome measures showed robust effect. And not only that, in the extension phase, the benefit continued. And in fact, despite not meeting the primary outcome measure, the drug was approved by FDA. And so, we have been using, now I don't know, have you been using Clozimab over here? It's a very expensive drug. We have used it. I just presented these results recently. We've got close to 7 patients of this drug now. Very highly refractive patients. They have got 4 or 5 agents we have tried. There's a patient who requires, I don't know whether you can see from there or not, but there's a patient who requires plasmapheresis every month. So we switched him to Clozimab. It's an IV infusion. It's given every 2 weeks. And most of our 6 out of 7 patients have shown significant benefit. And one of the patients who was on plasmapheresis every month for the last 1 year, he hasn't gotten a single plasmapheresis. So significant improvement over the current therapies, but still it's done, put them in remission. Still they have to go every 2 weeks to get the drug, but there's significant improvement. That's a long-acting form of Eculizumab, Ravulizumab. This is, the trial has just been completed. We are part of this trial as well and just been published as well. This one is given every 8 weeks. Same mechanism of action as with Eculizumab. This trial again showed that patients on this long-acting form had improved ADLs, QMGs, and again, improvement was rapid. Because it inhibits the complement rapidly, the onset of action is within weeks. We're not talking about months or years. It is within weeks you can see the benefit. Again, these drugs are Eculizumab as well as Ravulizumab. They are very well tolerated. The third new agent coming this line is Zilucoplan. It's a newer drug. It is given subcutaneously as compared to the other 2 I showed you, both are IV, there's sub-Q. And so that is a major advantage. They just finished the phase 2 trial and it showed significant changes, particularly in the higher dose group in this drug. So there's currently a phase 3 study ongoing, so we'll be hearing more about Zilucoplan. So complement inhibitors are one of the new kids on the block for this disease. Very effective, very targeted, and no major, so far, we've been using it for close to about, the longest I've had a patient is about 5 years. He was part of the original trial, the REGAIN trial, has been using it for 5 years, and hasn't noticed any adverse effect. I tried cutting it back. He's on every 2 weeks therapy. He's a priest in the church. He loses his voice talking, and he wants to talk a lot. So when he gives sermons, so he notices that I try to cut it back, but he says I lose my voice. So it doesn't cure the disease, but makes it worthwhile. Almost all these patients are on compassionate. It's very expensive, hundreds of $1,000. I think I'm only one patient I've got who's getting it through insurance. Rest are through the drug compassionate program by the pharmaceutical company. They get it free of cost. But again, I think the field is still developing, and with newer drugs coming like Zilucoplan and subcutaneous, I think it will evolve further. Let's switch gears now. This is the second line of therapies being tried in myasthenia. Anti-neonatal FC receptor antibodies. FcRn they call them, FcRn receptor. The FcRn receptor is a key receptor in the recycling of Ig immunoglobulins. So FcRn receptor is called FcRn because it was first found in the placenta in the neonates. it recycles the IgG. What happens is that IgG in circulation binds to this receptor, and it prevents the degradation. When it enters the cell, the binding of the FcRn receptor to this FcRn molecule to this IgG prevents the breakdown by the lysosome, and the IgG is recycled back into the blood intact. If you don't have the receptor or you block this receptor, this recycling will be markedly affected, and this is what happens. Agents which block this receptor, FcRn receptor, and if the IgG is taken as such into the endothelial cell, it's broken down, and it markedly prevents its recycling. And so agents who block that pathway cause rapid reduction of serum immunoglobulin levels. So here's an efgartigimod, the first agent in this line. Again, you can see over here the total IgG levels in the serum. Within days, when you give this agent, the yellow one goes down very fast. Within days, you reduce the level of antibodies. This is a phase 2 study in myasthenia patients. And you can see with rapid reduction of these antibodies, the scores improve, the ADLs and the QMGs. Again, they follow the path they follow the levels of IgG with rapid reduction in the IgG levels, which include acetylcholine receptor antibody, of course. The condition improves. This was the first trial done in these FcRn receptor antibodies. This was followed by a phase 3 trial, again recently done in efgartigimod. Again, 167 patients, 75% showed significant improvement in the ADL scores. And not only that, the effect was evident 1 week after the first infusion. Due to rapid reduction of the antibody levels, they improve rapidly. And not only that, this effect was visible in all clinical efficacies. When in these trials, we use multiple outcome measures. The effect was robust enough that it can be seen in all modalities. I think it has been sent for FDA approval, and it may have already received it. I heard last was that it was in the final stages. So you'll be just like eculizumab, this may be something will be approved in myasthenia therapy by the FDA. There are other agents coming, same modality. It's hard to say even the name. I have tried multiple times. I can't say the name. You can read it. Good for you. I'll try it, Neuromuscular, and this one was tried in a phase 2 trial. Again, recently published in the last year and a half or so. The results in 43 patients didn't meet the primary endpoint though, but as I told you, they used multiple secondary outcome measures. As the professor was saying, they were all showing they were going in the right direction. So they are now conducting a phase 3 trial in this agent. Finally, this RVT-1401, there's a third agent in the same FcRn receptors. You can see it has shown the same thing which the efgartigimod was showing, rapid reduction in antibody levels. The advantage of this one is it's subcutaneous. So they call it plasmapheresis with an IV drug. Use plasmapheresis over here? You don't do plasma exchange, huh? Plasma exchange, we don't do plasma exchange in Egypt. One of the most effective therapies, you know what plasma exchange is? They hook the patient up and over 5 treatments, they filter the antibodies. It's the most effective treatment for myasthenia, actually. This is plasmapheresis through IV. In plasmapheresis, you have to put a central line. It requires a big machine, and you have to drain the antibodies. You're doing plasmapheresis via IV over here, these drugs, FcRn receptor blockers. So that's why it's so quick, just like myasthenia, that's like Plex or plasmapheresis. They're relatively effective because the antibody level goes down pretty fast. I needed a couple of minutes, not long. So So the new agents, which are, I haven't told you about CAR T cell therapy. CAR T cell therapy is the third line. I mentioned to you complement inhibitors. I mentioned to you B cell therapies. I mentioned to you FcRn receptors blockers. Another line is CAR T cells. CAR T cells affect the T lymphocytes. The T lymphocytes also have a major role in myasthenia. They activate the B cells to form plasmablasts. And when the plasmablasts are formed, they enroll more T cells. So it's a positive feedback where the T cells activate B cells, and activated B cells bring in more T cells. The CAR T cell therapy is the third one. Just beginning, they are now changing. They are genetically modifying T cells and then reintroduce it. So they take out blood from the patient, isolate the T lymphocytes, modify it, and then infuse it back in the patient's blood. The latest, this was being done in leukemias and others, and now it's coming to myasthenia. So a number of avenues in myasthenia happening. It's a very exciting time. So I want to conclude that there are a number of novel targeted therapies coming to it in myasthenia, very exciting times. I showed you an initial slide. We didn't have, from 2002 to 2015, about 15 years, we didn't have even a single clinical trial in myasthenia. The last that was done was Celsepro, mycophenolate, early 2000s. After that, there was a lull period. And now in the last 5 to 7 years, currently at my center, there are about 6 NG trials ongoing. Around the world, there are about 8 to 10. So rapidly evolving therapies, they are expensive though. Monoclonal antibodies are expensive therapies. But what I'm saying is that 10, 15 years down the road, when a number of competitors come in the market, the drug price goes lower. So exciting times. I mentioned about SCIG. I'll be happy to guide your program if you want to set up the SCIG program or the subcutaneous immunoglobulin. Patients love it. It doesn't have any major side effects. Patients get a lot of flexibility in their routine. They can do it at their homes. Rituximab, you already know that. I don't want to preach to the choir. It's a highly effective drug. And then these complement and FcRn inhibitors. We are beginning to use them. The advantage is that very safe drug so far, what we experienced, and effective. The problem is the cost, so we'll see how it goes. I'll stop over here and take any questions if there are any.
Thank you, Professor Zaim, so much. I have 2 small questions. One of these is the use of rituximab in children, because I had one child with anti-mask antibodies, and she is refractory to IVIG and didn't give response also before it to plasmapheresis. Can we give rituximab in childhood group?
How old?
She's about 12 or 13 years.
Yes. Yeah, less than 10, but over 10, she's now 13. Anti-mask positive?
Anti-mask
yeah,
positive.
I would definitely give it to her, because think about what other options you have. You talk about steroids and plasmapheresis. So there is no study in kids, of course, but it's a relatively safe drug. I'll start at the lower dose regimen, and I'll definitely would advise you to try it because of its safety. I just give her vaccination before that, that's all it is.
When you treat the 20% refractory myasthenia gravis, do you use one by one according to first line, second line, third line, or you have another measure, biomarker measure, or any measure in these serum antibodies, for example?
No, there's no biomarker. So antibodies, I showed you level of antibodies, but there is no biomarker for myasthenia. It's clinical. None of the trials use a biomarker as a primary outcome measure. It's functional scores and lately ADL, activity of daily living, which is a patient-reported score. So the only robust biomarker you can follow is the physical exam of the patient. Coming to the question of how you use these drugs. In the past, we were using rituximab quite frequently. I showed you data on 24 patients. Now we've got close to 50 patients on rituximab. The problem is the cost. We are limited by the cost, and we have to show the government that first line, second line have not worked. Prednisone, azathioprine has not worked, and they are now asking us to use mycophenolate. And if they don't respond, then they allow us. In anti-mask, they allow it right away. But in seronegative patients or acetylcholine receptor antibody positive patients, we have to show the refractoriness of the condition because they are supplied by the government. For insurance, it's different. So in real life, you have to, ideally I would like to use them as a first or second line agent, but it's also if the, the practicalities of things. So bottom line is, it depends. If you're a patient who is not, particularly if a patient is not responding to steroids, or it's, you know that that patient is refractory. And if you have an opportunity to start them early, I would. I used to start them early, but now as the pool is growing, now they're putting more restrictions. But I've used it as a first line alternate right after azathioprine. And definitely, I'm a strong proponent of that because of its safety. And you don't require monitoring. All of the, I didn't mention that, all of the patients, azathioprine, cyclosporin, tacrolimus, mycophenolate requires blood monitoring. You have to monitor their blood in the long term, forever. In rituximab, you don't have to monitor. You give the we monitor the B cell counts, but that is just for our own research. There's no monitoring required. All of the drugs they require monitoring for liver functions, blood counts, some cyclosporin, you need renal function monitoring. So that's the advantage of rituximab. I am a strong proponent. Early, if you can, use it early. And the onset of action is you will see an effect, in my experience, within 6 months. Most commonly in 4 months, but some patient may have a delayed response, 6 months, 7 months, but this is the fastest after steroids we get. And we require, the effect lasts, in my hands, what I see is about 8 to 10 months minimum. I've got a patient in rituximab, she comes and gets infusion every 3 years or 4 years. So that's, she's gone in remission. So I think it's a great drug with myasthenia, I personally think.
Thank you, Professor Zaim. I want to ask you about the rituximab in your practice. You said that it is more effective if the patient is mask positive.
Yes.
And if the patient is acetylcholine receptor positive, is less effective.
Marginally. It's not as robust, but it's effective. Anti-mask is like a given. Huh? You see, it's I won't call it dramatic, but very robust. Okay. In anti-mask, in the acetylcholine receptor, you can reduce the prednisone quite a bit. Prednisone reduction becomes much more easier. In anti-mask, you can even stop the prednisone. So that's the difference. But in there you can, but it is effective in both group of patients, shown by multiple studies. The one I showed you, that just published recently, it showed it was in acetylcholine receptor antibody positive myasthenia. Quite robust effect.
Okay. In our practice in Egypt, we found that acetylcholine receptor antibody positive are more prevalent than the mask positive antibodies. Yeah. And usually now we use rituximab for the treatment. Oh, very nice. So I want to ask you, if the patient is resistant to plasmapheresis or for IVIG, can I use rituximab as a rescue management?
So rescue management means that you are trying to get the patient very early. Rescue means that rescue means urgent, immediate. There's nothing better than plasmapheresis with that. So I don't expect rituximab to work. I'll tell you something if you ask me that question. Let me finish with rituximab. Rituximab can't be used as rescue because it takes 4 to 6 months to get into the system. So 4 months. So when you talk about rescue, is IVIG and plasmapheresis. But here's the rescue medication. My slide still up? No, it's gone. Of the 7 patients I showed you in eculizumab, the one I showed you my data on eculizumab, one of the complement inhibitors. They called me one night. It was a Friday night of the weekend. Young woman struggling in the ICU because she didn't have, she had received high dose prednisone and plasmapheresis, multiple treatments, and she was not responding. So the on-call neurologist called me. It was a Friday night. He said, what are we going to do? And I said, you know what? Let me try. So I called the drug company. I said, can you give us release the eculizumab on the compassionate basis for a patient? It was Friday evening. By Monday, they approved it. The approval has to go to her. We started infusing her eculizumab. And that patient, after a week or 8 days, she had already gotten a tracheostomy because she would not respond to plasmapheresis. She got out of the ICU and did well. Tracheostomy was closed, and she walked out of the hospital. She had thymoma, malignant thymoma. Malignant thymoma, when you have a malignant thymoma, they're very severe myasthenic. If you dealt with that, you'll know it. So this woman had malignant thymoma, and she did well. So that was rescue therapy. If somebody is not responding to plasmapheresis, first of all, you make sure the diagnosis is correct, because plasmapheresis is the most effective 80 to 90% time. I would say 80 to 85% is effective, but there are always resistant patients, and so I will give them high dose, maybe Solimedrol or whatever, and try apheresis again. Sometimes they respond after 10 treatments. I've used 10 treatments rather than 7 or 5. Usually we do 5 treatments. I've done 10 times, and they ultimately do respond. I don't want to take somebody else's time. Oh, yes.
Yeah, we will. Thank you for your
Absolutely.
very interesting talk. We have now fast antibody-reducing drugs inside, as you mentioned. Traditionally, in our country, we use for fast reduction immunoabsorption or plasmapheresis. How is the role of both therapeutic intervention in the future? Is there a role for immunoabsorption and plasmapheresis in the future?
Yeah, I think with the new drugs coming in, with the plasmapheresis, as you know, these patients has to be in the hospital many times. They need almost always they need a central line, and you can only do it for that long. And I think with these drugs coming, what I'm seeing over here, with the rapid reduction of these antibodies through these agents, I think these agents will soon take over, because this is plasmapheresis being done through IV drugs. Similar, you can see the rapid reduction antibodies, there's no question. So I suspect the role of plasmapheresis. And the other thing is plasmapheresis is only available at major academic center. In my province, there are only 2 hospitals which does plasmapheresis. So I think with time, what I see in the next 5 to 10 years, that these drugs will slowly take over the plasmapheresis. That's what my opinion is.
The last question, Professor Zaim.
Yes.
For the patients with myasthenia acetylcholine receptor positive antibodies, in the management by rituximab in comparison to the anti-mask or the mask positive, you can give the patient with mask positive a different regimen of rituximab differs from that patients with acetylcholine receptors antibodies regarding the dose, maintenance dose every 6 months, and regarding the duration of the treatment?
Okay. So, excellent question. When we started this drug about 7 or 8 years back, the regimen was totally different. Europeans were using differently. They would give 4 infusions 1 week apart, then a 5th infusion and a 6th infusion. The whole treatment would be completed in about 2 months. Slowly we learned that we don't need that much rituximab. So they reduced it to 4 infusions IV weekly. Then we again learned that you don't need that much. Currently, what we are doing is 1 gram IV times 2, 1 week apart. So 2 infusions, 1 week apart, 1 gram IV. Okay. Now they're coming down to this new study has shown 500 grams every 6 months. This is a new regimen. So the regimen has not been, there's been never shown that the 2 forms of myasthenia require a different dosing regimen. It depends on different centers, different region of the world. The most popular regimen right now is 1 gram dose twice, 1 week apart, and then every 9 months to a year give 1 gram maintenance dose. So the most common regimen, 1 gram twice to induction dose and maintenance dose of 1 gram IV once yearly, 9 months to a year. That is the current regimen. It may change, there are no trials, but that is what I'm telling you, the current. Does that answer your question?
Yes.
No, there are no biomarkers, so we don't go by. You will even if you see after a year, the B cells will still be 0. That's very interesting. It's such a significant depression of B cell counts that if you check them, and we have done that, it's not related to the B cell count. You can't, the clinical response. Despite having 0 B cells, when you look at the CD, we still infuse them because the patient is showing the signs of relapse, early relapse. So we have now learned that rather than waiting for the patient to relapse, it's safer to find a regimen a yearly, because when the patient relapses, it takes him time to gain back. So 1 gram a year is a safe dose, even in patients. Sometimes you can push it a bit. So every patient is different. But my practice now has become is that we, about a year, we infuse them, 1 gram maintenance dose.
Plasma exchange and IVIG on a long term. So instead of giving these therapies so frequent per year, when you decrease it using such medication, this is by itself a success.
Absolutely.
You decrease the cost. I mean, the aim or the main target of therapy not to wholly putting the disease under control, because as you see, there is a complete heterogeneity among the pathophysiology of the disease. So with time, you need only to decrease these interfering.
Absolutely. So that's one of the major markers of disease. When a drug is effective, one of the major things you want to see, not just by clinically, but if you are able to reduce other therapies, IVIG or plasmapheresis. And that's one of the key things we watched in almost all these patients on rituximab, most of them, we will be able to cut down. IVIGs are very rare in these patients when you have them stabilized. Very rarely we do that. And same thing for prednisone, and over time, we are able to gradually taper them. The problem is you don't want to, you have to be very gentle. You have to go slow. If you take them off everything and they relapse, then it's a problem. So in most cases, it's clinical improvement and the improvement of the drugs, what they're on, or the therapies they're on.
One more question about corticosteroids. I see most of our staff here are very cautious about using higher doses of steroid for treating myasthenia. And I have encountered a lot of specialists in myasthenia gravis centers, and they use higher dosage, and most of their patients are on steroid rather than all these medications.
Yeah.
So what's the average dosage of steroid that you go for it and you don't hesitate going for it?
So for the trainees, if there are trainees over here, you never use steroids. You do never introduce steroids in a patient who's not doing well in myasthenia. That you never do, okay? You never put a myasthenia on steroids, patient with myasthenia who's the first time and using active symptoms, particularly bulbar symptoms. They'll go worse. Now where to start? Should we start at 10 milligrams then go up, or start at 60 milligrams then go down? And there are 2 schools of thought. The person who I trained under Don Sanders, he is a big proponent of high dose steroids. Back in the 90s, he would start at 60 or 70 milligrams daily and then slowly bring down. The other school of thought is start with 10, 20, 30 every 2 weeks or whatever and go up. Both have pros and cons. When you blast them with steroids, your chances are that you get a robust response early. But I have a patient who had pulmonary embolism, PE. Steroids are thrombogenic. They can cause a lot of, they can have side. So over years I have learned to go slow. I start with 10, 20 and they'll go up to 30. And by 30 it takes time for the response, but they do respond. Ultimately, the response is slower. So my suggestion to you is, whatever you feel, I go slow. I don't go at a pulse dose, though people do it. There's nothing wrong with it, but it's just that the chance of side effects are more, and it's based on what you feel.
Thank you for your demystifying lectures and nice presentation. You mentioned a lot of drug for the treatment of myasthenia gravis. On what basis can I select the suitable drug? Is it depend on clinical presentation, lab, or benefit versus risk? Thank you.
So yes, we tailor the drugs in certain ways. In certain patients, we tailor the drug. In young women, for example, you mentioned high-dose steroids. I never use high-dose steroids in young women because, myasthenia is much more common in younger women and older men. So yes, there is always, the other name for myasthenia is snowflake disease. Snowflake, like the snow, no patient is same. Everybody, each patient is different. So we carefully select the patient. How do I select the patient? Age, number one, and gender. Age and gender are very important. Then we talk about other comorbidities. A number of these patients have diabetes. You give them high-dose steroids. So it's not the disease mechanism of action right now. It's more somebody who got liver disease, Imuran is out. I don't give Imuran to patient liver disease. In older patients, cyclosporin, they've got borderline kidney function. You will put them, somebody with hypertension, cyclosporin. So there are a number of factors which when you choose a drug. So steroids are, yes, steroids are the main line of therapy still. You use it sparingly, pick the patient rightfully. I would rather somebody with young girl present to me, I'll give her a course of IVIG, send her for thymectomy if it's seropositive myasthenia. And a little bit of steroid, I don't know what shoy or whatever you call that Arabic, small steroids, just sprinkle a bit to get her over the thymectomy and see what her response to it. So I buy time for those girls. Myasthenia management is a bit, it's subjective, plus you look at overall picture. The newer drugs which are coming, for sure, will have more targeted, and again, we'll choose patients for them. These drugs which are coming are for refractory patients, patients who have severe myasthenia. I don't think they'll be used routinely in the next 5 years or 10 years because of the costs. We still depend on these drugs, older drugs. But my management is a lot of factors. I can't tell you do this for this patient.
Okay.
If there's an older patient, 50 or 60-year-old male, I might be more generous with the steroid with that person.
Okay. Thank you, Professor Zaim, for the great discussion and great lecture. The end of the session and start a new session.
Bismillah ar-Rahman ar-Rahim. We shift to the next session. It will be the International Medical Center and the Army Hospital. Dr. Hani Tahir, Nasser Institute Hospital. There is Zoom meeting.
We are now in Novartis Symposium. Let me introduce our professor. He will be in Zoom with us from the United States. Professor Richard Finkel. He's a pediatric neurologist and directs the Center for Experimental Neurotherapeutics at St. Jude Children's Research Hospital. Dr. Richard has a clinical practice and research interests have focused upon neuromuscular disorders, especially spinal muscular atrophy, Duchenne muscular dystrophy, Charcot-Marie-Tooth. And he has participated in numerous clinical trials and natural history studies and has contributed to the development of standard of care guidelines, outcome measures, and clinical trial design. He has published over 200 manuscripts. Dr. Finkel also received the Sidney Carter Award in Child Neurology from the American Academy of Neurology in 2018 and shared the International Prize for Translational Neuroscience from the Max Planck Institute in 2019. Welcome, Professor Richard Finkel. Connection.
Okay. Hello, my name is Richard Finkel. I'm a pediatric neurologist, and I work at the St. Jude Children's Research Hospital, which is in Memphis, Tennessee, in the USA. And I really appreciate the opportunity to speak with you today and share some of my thoughts and experience as it relates to the management of patients with spinal muscular atrophy. What I hope to share with you is how we have really had a big transition in the last few years from what is called reactive care, meaning dealing with problems once they come up, to trying to anticipate them and deal with them before they actually surface. So these are my disclosures. I do want to let you know I have research support from many different pharmaceutical companies that I've worked with. I've also served in an advisory capacity to several companies, including Novartis, which is sponsoring this symposium. And I've served on a data safety monitoring board for a few clinical trials. And I also serve on some foundations and have co-edited a neurology textbook. And I received some licensing fees for having developed a scale for SMA called the CHOP Intend. So you've heard from other speakers already in this week of different talks about spinal muscular atrophy and how it's one of the most common pediatric neuromuscular disorders. And while it's rare, it's not all that rare, and a pediatric neurologist and even a pediatrician will be encountering patients with SMA somewhat regularly. This slide is just a very quick summary of what's happened in the first 100 years since Verdnick and Hoffman first identified SMA in the late 19th century. And it took about 100 years until the discovery of the SMN gene that causes SMA. And then about 20 years after that, were the first standard of care guidelines published, and these were then updated about 10 years later. And I'm going to focus on that today and give some examples and why I think that's so important. And it took about 20 years after discovery of the gene in 1995 by Judith Melke and her colleagues in France until there was the first of 3 US Food and Drug Administration approved drugs for the treatment of spinal muscular atrophy. And that was the antisense oligonucleotide nusinersen. And then it was followed 3 years later by the first gene therapy treatment for SMA on asemagene apapervovac, and then a year after that, an oral splicing modifier for SMA called risdiplam. So you've already heard about the genetic basis of SMA, but I want to highlight a couple important things. As you know, there are these 3 main types of SMA. Type 1, these are little babies who never achieve independent sitting. Type 2, these are infants who develop sitting but never achieve independent walking. They may stand, but they don't walk. And over time, they may lose those skills. So they may lose standing or sitting. And then there's the type 3 patient who achieves walking but may lose this as the disease progresses. And shown on the right is the relative incidence of SMA. About 58% will develop type 1, about 29% type 2, and type 3 is in about 13%. And there's very rare type 0, which are babies born with very severe contractures and weakness due to fetal onset of the disease. That's under 1%. And there's a type 4, which evolves in the adult years, which is probably also around 1 or 2%. So the most common ones that we see are type 1 and 2. Now, with the advent of these new treatments for SMA, we've really had to change how we look at the patients. And it's no longer appropriate to characterize a patient as type 1, 2, or 3, but rather to look at them from their functional capacity. At the moment that you see them, are they a non-sitter, a sitter, stander, or walker? And we generally use these 4 categories to characterize the patient. And the reason for that is that you may have a patient who was type 1, but treated with one of these 3 new medications, and now they're a sitter. So that doesn't really make them a type 2 because the phenotype is really quite different from a type 2. But functionally, they are now a sitter. So the incidence of SMA varies across different studies. It's approximately 1 in 10,000 live births worldwide. And the carrier frequency is pretty high. It's about 1 in 54 overall, but there is some ethnic variation. It's higher in some groups and lower in others, but about two people out of 100 are a carrier for SMA. And because it's autosomal recessive, if both parents are carriers, each of their babies has a 1 in 4, 25% chance of having classic, what's called 5q SMA. 5q because it's on the long arm of chromosome 5. Now, there seems to be a higher frequency of SMA in Egypt, which could at least be partly attributed to the higher degree of consanguineous marriages, which is about 45% of those patients that have SMA type 1. So shown here, again, in this cartoon on the left, is the representation of autosomal recessive inheritance patterns that's already familiar to you. So this is the 1 in 4 with a child with SMA. Over here, okay? Now, I want to turn now from changing from incidence, which is about 1 in 10,000, to prevalence. And the prevalence is the population of patients living with a certain disease, in this case, SMA. Worldwide, it's around 2 per 100,000, but in Egypt, it's really quite a bit higher. It's almost 18 per 100,000 individuals are living with SMA. So neurologists and pediatricians are going to see patients with SMA more regularly than in some other countries. I want to remind you now about the relationship with the number of copies of SMN2, okay, and the phenotype. So shown here in these light blue bars are patients with SMA type 1. That's what we're focused on, the most severe type. And you can see the majority, over 70%, have 2 copies of SMN2, whereas about 7% or so have 1 copy, and about 18% or so have 3 copies. So what we know here is that if you have 2 copies, it's highly predictive, not certain, but highly predictive, that you're going to be type 1. But you can see also if you have 2 copies, there's a small, maybe 10% chance of being type 2 in the purple, or even a type 3, a small percent. So you cannot look at the copy number and say for absolute certainty if a baby's going to be type 1 or 2 or 3. But you can say in high likelihood, if you have 2 copies, you're more likely to be type 1. And you can see that if you have 3 copies, that you're more likely to be a type 2. But not certainly. You could be a type 1 or you could be a type 3, as shown here. So you need to keep that in mind, particularly with newborn screening, because the way that we make the diagnosis is with determining the homozygous deletion of SMN1, but also we get the copy number. It's really important we get the SMN2 copy number, but it's important that we don't try to make a firm diagnosis, because it's not 100% prediction between copy number and the phenotype. So the SMA phenotype is now seen as a continuum. Okay, so shown here is a very nice figure, and it looks at the classical type 1, type 2, type 3, and it looks at it from the copy number, like I just showed you. So shown over here for type 1 is that you can see here 73% in this study have 2 copies. Okay, and if you have 3 copies and you're type 1, there's about 20%. But also shown here is that you can look at the patients by their functional status, non-sitters, sitters, or walkers. So this is a nice figure because it shows both the SMA type and the functional status, as well as the predictive copy number. So the newer classification recognizes the SMA phenotype as a continuum and looks at the current functional status and the therapy response. So I want to turn now to the diagnosis and screening of SMA and just summarize a few important points. In the United States, we're now screening about 97% of newborns are being screened for SMA. So that's allowing us to identify babies, in many cases, before any symptoms appear, we would call pre-symptomatic. Without newborn screening, the initial diagnosis is made on clinical presentation in the weakness, hypotonia, weakness, motor delay, breathing difficulty, feeding difficulty. We use the genetic testing to confirm the diagnosis and to anticipate the expected severity. And as I mentioned, knowing the SMN2 copy number is particularly important to help guide you in making the decision about treatment. And I'm not just talking about medication treatment, I'm talking about supportive care, which I'll get into in a moment in more detail. Early diagnosis is critical because we've learned from the clinical trials that the earlier that we start treatment, and that's whether it's symptomatic or pre-symptomatic, the better the outcome for the individual. So shown here are some of the different clinical features that are typical of the infant with SMA, with hypotonia, the floppy baby. And it's proximal symmetric weakness, and it's in the legs more than the arms, and that's why these babies have that classic frog leg posture. There's the abdominal or paradoxical breathing pattern. There's bulbar muscle weakness, and that can be exhibited by difficulty handling their oral secretions, difficulty feeding and swallowing. When the disease is more advanced, you'll see tongue fasciculation and atrophy. There can be failure to gain weight because of the difficulty in feeding. And often early in the diagnosis phase, there will be areflexia or at least hyporeflexia, difficult to obtain reflexes. And as you know, it should be pretty easy to get patellar reflexes at the knee in a newborn baby and infant. So when there's difficulty in getting them or absence, that often is a major clue along with these other features. In the patients that have type 2 SMA, they present a little bit differently. They also have hypotonia and proximal weakness, but they tend to hit a plateau in their motor development. They sit and then they simply don't attain further developmental milestones. In some cases, they'll attain standing, but not walking, and many of them never attain crawling. In addition, over time, there can be musculoskeletal changes, including scoliosis and joint contractures, which are very typical of SMA as the course evolves. So summarized on this table is the type 1, type 2, type 3, by age of onset. Type 1 is typically, not always, but typically less than 6 months of age. Type 2, typically 6 to 18 months. Type 3, typically 18 months and older, even into the adult years. And as you saw on an earlier slide, the relative incidence is about 60%, 27, and 13. Okay, and we've already mentioned that type 1 never sits, type 2 never walks, type 3 walks, but the important point here is that these skills can be lost over time as the disease progresses. And looking at survival, and this is natural history survival before we had the opportunity to treat with these 3 medicines, that only about 30% of babies with SMA type 1 were able to reach their 2nd birthday, and that is with supportive care. Whereas type 2, about 68% were alive at 25 years, and now that's even higher due to better supportive care. So this is more historic natural history data. And for type 3, the survival is typically normal, even though there is motor impairment. So here's a baby with SMA type 1, the frog-leg posture, the weakness in the arms. You can see the bell-shaped chest and the kyphoscoliosis. And here's a child with type 2 who can sit, but is unable to get his hands up over his head. So, and he cannot stand or bear weight, and he cannot crawl. And here's a little girl with type 3, and she can walk, but you can see from her stance that she doesn't even stand or walk normally. So what I want to do now is show you a video So on the left, so on the right here is a video of a child who's 32 months, and this is end stage. This is with tracheostomy, gastrostomy tube, full supportive care, but she's quadriplegic. So with typical supportive care, we've been able to prolong life expectancy. She's more than 2 years old, but she's getting progressively weaker. What I want to show you now are some twins. Okay, so this is a little boy at 6 months of age, and I'm pulling him up to sit, and you can see that he's the healthy of the two twins, and I try to lift him up in his arms, and he does very well. He bears weight. I tip him to the side. He's got good head and neck control. He's having a fun time, and you can see he's got normal tone and posture. And when I put him down, he anticipates and lifts his head up, and he can prop himself up, and he's trying to roll over. And I want you to compare that to his sister over here, who has SMA. And I'm going to do the same thing, but very gently. First, I'm going to try to pull her up into sitting, and you can see the extreme head lag and the lack of shoulder fixation. And I'm going to lift her up under her arms in a minute, and you'll see that she'll slide right through my hands, that there's no ability for her to fixate at the shoulder girdle. And that's done right here. And she's starting to fuss a little bit and be unhappy. So here we go, and see how she slides through my hands. And she also has no weight bearing. She just crumbles there, unlike her brother. And you can see when I try to turn her into prone position that she forms an omega sign, and she has really no response on the Galant or Landau responses, and she's unable to extend her head and neck when I put her in prone. So that's a pretty striking example. And this was before there were any treatments for SMA, about 10 years ago. And this little baby died with a pneumonia about 2 months after this video was taken. But I want to share now a video of a baby who received extensive supportive care. You can see the tracheostomy. She has gastrostomy tube. She's had all the supportive care one can imagine. And she's now about 2.5 years old, but she's basically paralyzed, quadriplegic. And she's alert. She can respond by blinking, by moving her hands just a little bit at her fingers, but basically is quadriplegic. So the point here is that even with massive supportive care, without these new drugs, we were able to increase the survival, but the babies were still getting weaker. It did not improve their motor function. So one of the points I want to emphasize is that we use the term time is neurons because we know this is a progressive neurodegenerative disorder. And in fact, some of the neurons are lost during fetal life. So a baby with SMA type 1 has already lost some motor neurons before birth. So it's particularly important that we try to rescue them as soon as possible with one of these medications. We also know that the motor neuron loss is most rapid in the first 6 months of life. So not only do we need to identify these babies early, but we have to start treatment as soon as you identify symptoms and make the diagnosis. And if possible, even pre-symptomatically, if newborn screening is possible. And when there's a positive family history of SMA, then of course you have the opportunity to check other babies born by those same parents to see if that baby in fact has SMA shortly after birth, based on the genetic testing. Now, unfortunately, there is often a diagnostic delay from the first symptom until diagnosis is made. And during that period of time, during the delay, there can be further loss of motor neurons, as is shown on this slide. So what is shown here is survival in the gray, when typically nutritional support is needed by 8 months, and this is for babies with type 1. Ventilation support no later than a year, and that progresses to permanent ventilation support just a few months later. So early diagnosis is the key for improved outcomes. Timely diagnosis, assessment, and management of SMA improves survival rates. And I'll show you some data that supports this in a moment. We also know from different research studies that SMN protein expression declines, as I mentioned, during the last trimester of fetal development and the first 3 months after birth, that neurodegeneration occurs early in SMA disease course, and motor neuron loss is an irreversible process. You can't rebirth these motor neurons once they have withered away. We need to act on early clinical suspicion with early referral because early diagnosis is really paramount in preventing motor neuron loss and trying to optimally rescue these babies. So newborn screening and SMN induction treatment as soon as possible will maximize benefit. But when you see a baby with hypotonia and weakness, SMA needs to come right immediately in your mind because this is one of the few conditions that's actually treatable. But shown here on this slide is that there are other neuromuscular diseases and other neurogenetic conditions that can mimic SMA and are in the differential diagnosis. And shown here is congenital myotonic dystrophy type 1, Prader-Willi syndrome, congenital myopathies, and Pompe disease, so a metabolic disease. And there's certain similarities as shown here, but also certain distinctive differences on them. So I'll just let you take a quick look here, but some of the distinctive features for SMA again is symmetric proximal weakness. It's in the legs more than the arms, and the tongue fasciculation is a clue. The lack of reflexes, of course, and the paradoxical breathing pattern. There are other features that give you a clue about some of these other conditions. So, for example, cardiomegaly or hepatosplenomegaly in patients with Pompe disease. So the clinical examination can help to obtain a differential diagnosis. And in the first 6 months, we focus particularly on the legs and trunk. And in the 6 to 18 month, which is when the type 2 patient typically evolves, we'll see more of a modest reduction in muscle tone and strength in the legs more than the arms. But it's not as profound as in the babies. And there are other features, as I tried to show you on the video. The head lag, unable to lift the head, poor head control, poor truncal control, etc. And as I mentioned, the reflexes may be absent or reduced, the cry may be weak. And later on, we will typically see the development of scoliosis and joint contractures. Now, importantly, even though the parents are carriers in about 98% of the cases, both parents are carriers, their physical exam is normal. So there are no clues by examining a parent, unlike some other diseases where you can find some clues. For example, myotonic dystrophy, which is a dominant disorder, typically we will find some abnormalities in the mother when there's a baby with congenital DM1. So turning now to newborn screening, I want to emphasize again that it's really crucial to try to ensure the early diagnosis of SMA and allow the initiation of treatment and supportive care measures. This has been accepted internationally as a preventative public health program, and it's critical for the identification of many disorders for which there is an early treatment and where that treatment makes a difference. So we know that if we can treat before symptom onset, we can eliminate what's called the diagnostic odyssey and we can improve the response to these drugs. So now I want to turn to the management of spinal muscular atrophy. The guidelines for the standard of care in treating patients with SMA was updated in 2018. And this was a group effort, so it's really expert opinion with data to support this where available. But there's been a big shift from what's called reactive care to, let's go back here. So what was reactive care? Meaning once a baby had feeding trouble, you would work with the dietitian and with the GI specialist. And when there was breathing trouble, you would then refer to the pulmonologist, or after they've had their first pneumonia or respiratory failure. Now we know that that's not good enough. We really need to initiate this care pre-symptomatically. But there is still a role for palliative care. It used to be palliative care was comfort care that was end stage, but that's no longer the case. We use palliative care throughout the life cycle of patients with SMA because we do know that providing comfort care is important, even when we're giving other forms of supportive care and medication. There are differences in standard of care practice that we need to recognize, different sociocultural differences, geographic variability, and is there equal access for the implementation? This slide, I think, is particularly important, and it highlights the requirements for a multidisciplinary approach. Patients with SMA would benefit by seeing multiple different providers with different types of expertise, all working in a coordinated way for the benefit of the patient. So that would include typically a pediatric neurologist, genetic counselor, a pediatric pulmonologist, and ideally one who understands SMA and the nuances of this disease, an orthopedic surgeon, and then again, palliative care, gastroenterologist, and importantly, therapists, physical, occupational, speech therapy. Now, the ideal situation is to coordinate these activities in the clinic. So we have a multidisciplinary clinic. That's not always possible, and it might be because the patient doesn't live near a center of excellence, and they have to get this care locally with different providers. Or it may be that the children's hospital isn't set up to provide multidisciplinary care. But whenever possible, we do feel that having a child cared for in a multidisciplinary clinic that focuses on SMA, that's a center of excellence, provides the optimal opportunity for coordinated care. And I want to point out also that these drugs are really fantastic. We have 3 great drugs that really help these babies with SMA, but they're not cures, and they do not work in a vacuum. They work best when the baby is receiving multidisciplinary supportive care, and when it's proactive care, when you're still watching carefully for weight gain and working with the dietitian and the gastroenterologist if need be, when you have the physical therapist seeing the patient regularly, etc. So the key considerations for the care of patients with SMA type 1 are listed here. And we've highlighted in bold some of the points that I think are particularly important. It's to have the cough assist, the insufflator, exsufflator cough assist device, and to be able to initiate bilevel non-invasive ventilation support, what's called BiPAP. And we're starting to do this more proactively. We're not waiting for the baby to have difficulty with handling secretions, because we know that's already too late to be able to start this. You want to get the equipment available for the parents at home, let the baby get used to the cough assist and the BiPAP. We want to avoid getting to the point that they need tracheostomy. We want to make sure they have the proper equipment to do oral suctioning if they need to at home. because the little suction bulb for the mouth doesn't get far enough back. You really need that suction pump and a catheter to be able to get further back in the throat to clear the secretions in some of these babies so they don't aspirate. Routine immunizations are important, including for influenza and for the respiratory syncytial virus vaccine. And these are detailed in the standard of care guidelines that were published in 2017. And I would encourage you to look at those guidelines for any specific details. To continue, there are also details on nutritional support. Because we see now with some of these babies who are being treated with these drugs that they feed actually very well, but they tire. And that means that as they get older, they're not able to feed sufficiently well to get their nutritional input to gain weight. So they're able to drink, they're able to swallow solid food, but they take in insufficient amount of calories and maybe insufficient fluid. So some of these babies, even though they're feeding well, they still need a gastrostomy tube to provide supplemental nutrition, usually at night when they're sleeping. And if they get sick, if they have a gastroenteritis, you know that you can always get more fluids in them so they don't get dehydrated. We also know it's important to avoid fasting because these babies are at risk for hypoglycemia. Orthopedic management includes focusing on bone health, so that's with DEXA scans, to look at the bone density, to look at their calcium intake, vitamin D supplements. So this is where the dietitian and nutritional specialist is particularly helpful. We also look with the physical therapist on stretching, supportive devices such as immobilizers and splints, scoliosis that we monitor with x-rays, and when necessary, we have pretty good standard of care guidelines now. Once it gets to a 50-degree Cobb angle, we really need to think about surgical correction, even in young children using the growing rod constructs. And now that these babies are living longer and getting stronger, a lot of them are starting to weight bear. So we have to monitor how their hips are doing. A lot of these babies have hip subluxation and dislocation, and we're starting to focus more on the orthopedic management of these hip issues. And as I mentioned, the use of the gastrostomy feeding tube and with ventilation support with the cough assist and BiPAP is important for improving survival, as is shown here, okay? But also for improving quality of life. And now that these babies have these different treatment options, it optimizes their ability to respond to these drugs. So this data comes from before there were any of the new drugs available. And it shows that even with supportive care, with gastrostomy tube and BiPAP support, that there was a marked improvement in survival on this Kaplan-Meier curve, okay, from babies born in 1980 to 94, before BiPAP or G-tubes were commonly available, and comparing that just 10 years later, again, before there were any of these magic drugs. But you can see the marked improvement in survival with supportive care. But with that supportive care, unfortunately, these babies still decline in motor function. So the best they do really is at the time of diagnosis. And that was highlighted by the video I showed you of the baby who had received supportive care but was largely quadriplegic. So now I want to touch base on how do we actually assess these babies? What kind of test measures do we have? So we have the CHOP and TEND, which is used for babies. There's the Hammersmith Infant Neurologic Exam, also for the babies, the Bailey 3, and now there's even a Bailey 4 that's out, which is for babies all the way up to 42 months of age. The World Health Organization Motor Milestones, motor function measure, the Hammersmith. Now this is confusing because there's a Hammersmith infant exam, and there's a Hammersmith functional motor scale, and this is for the older children with type 2 and 3, the sitters, standers, walkers. The upper limb module is to look more at arm and hand function, and then in the ambulant group, the 6-minute walk test. So the point here is that we have different measures, and in our clinic, we prefer to have the physical therapist or occupational therapist who are trained in how to administer these properly to try to do these regularly. In the babies, you're going to do it sometimes at every visit. In the older child with type 2 or 3, you may only need to do it once or twice a year, so not at every visit. But it helps you put a number on how the baby's doing. There's a metric, and it helps you look at, are the babies actually progressing or not? So this slide goes through the different scales, and it looks at babies who are type 1, type 2, the sitters, type 3, the walkers, and which scales are useful in these different domains. So in the younger babies, the CHOP and 10, the Bailey, the WHO motor milestones, and the Heine, the infant exam. Whereas the older children, as I mentioned, the Hammersmith functional motor scale expanded, the revised upper limb module, the MFM, and then the walker 6-minute walk test. So you need to select the right test for the right patient, okay? For the CHOP and 10, it really loses its benefit after about age 2 years. And the Hammersmith doesn't really start to be valid until 2 years of age. So you need to know both the functional capacity and the age of the patient to select the right scale. So finishing up, I want to just talk about the treatment landscape. And you've already heard from other speakers that we have 3 therapeutic options for the treatment of SMA. And I'm just going to briefly touch on this. You can replace the missing or faulty SMN1 gene with the gene therapy. That's the onasemagene apapervavac. Okay? And there are 2 drugs that target splicing of the backup SMN2 gene to promote inclusion of exon 7 into the mature transcript so that you make a full-length protein. And that's what nusinersen, an antisense oligonucleotide, and risdiplam, a small molecule drug, do. Now, there are other drugs in development that are totally different from focusing on the SMN protein. And these are muscle activators. And they work in different ways, but these are in clinical trial and clinical development. Okay. So I've already mentioned this, that we have the onasemagene apapervavac, which is a one-time, it's a single dose, it's administered IV, okay? But it can cross the blood-brain barrier and get to the target motor neurons. There are clinical trials now underway to look at intrathecal administration of this as well. But the current FDA-approved indication in the US and in Europe is for the intravenous form. And this is weight-based, so it's dosed on a per kilogram basis. And it is important to mention that although it's not approved in Europe, it is reimbursed, so it has a reimbursement status. So it is available for patients in Egypt. Nusinersen, which is the ASO, is given intrathecally, so it requires repeated lumbar punctures. And after their 4 loading doses in the first 2 months, then it's given every 4 months. Now, this is approved for all patients, and it's a fixed dose. It's 12 milligrams that's given whether you're a little baby, identified by newborn screening, or an adult. Although there is a new study going on to look at a higher dose regimen to see if that works any better. Now, this drug is approved in multiple countries, including the US and Europe. And again, it is reimbursed in Egypt, although it's not yet formally approved as such. Now, risdiplam is the oral splicing modifier. It's taken daily, and it crosses the blood-brain barrier, and it elicits modification of splicing similar to nusinersen. And it's approved for patients of all ages in the United States, from newborns all the way up to adults. And it's approved in multiple countries, including the US, Europe, and it is approved in Egypt. So it's registered for treatment in Egypt. So turning now to gene therapy, it's designed to address the genetic root cause of SMA. I just want to summarize a few important points. Excuse me. So this is an SMN1 directed therapy. Okay, so what it's doing is it includes the full SMN1 gene, as I'll show you on the next slide. Okay, so this is the SMN1 human transgene, and it's packaged inside an adeno-associated virus type 9 vector. And it has certain enhancers and promoters that try to target, in particular, the motor neuron. And it's very clever in the way that it was designed, so that once it's administered intravenous, it crosses the blood-brain barrier, it gets into the target motor neurons, and it gets to work pretty quickly, it seems, to start to generate the SMN1 gene in the nucleus, which then generates the SMN protein in the cytoplasm, which is what's needed for the survival and the function of these critical motor neurons. And then this slide just summarizes the clinical development program, starting at the beginning with the START study, and then the STRIVE, the confirmatory studies, all of which supported regulatory approval in the US and Europe. The SPRINT study was a pre-symptomatic study, and then there's the STRONG, the intrathecal study, which has been completed, and now the STEER, which is an ongoing, it's still just started recruitment, actually. And then there's a RESTORE registry, which is trying to capture patients treated in the real world with a variety of medications, but in particular, the onisamogene apapervavact. I'm not going to spend too much time on this other than to say the very first study was striking. There was a low-dose cohort that did show some slight improvement, but you can see the high-dose cohort that got the gene therapy, that there was a rapid increase in the CHOP intent, and then they reached what's called the ceiling effect, where they actually couldn't go much higher, because the maximum is 64 points on this scale. And this is really very striking and led to early FDA approval for this drug. And there was improved survival as well, so the natural history studies, 25%, whereas in that study, the START study, 100% survival at that endpoint. And half of the babies were sitting unassisted, again, at that time point. And many of the babies even later developed and acquired this skill to be able to sit. And they're continuing to improve. We're finding that this is a durable effect, it's sustainable, so not only are they achieving things like sitting and rolling, and in some cases standing or even walking, but they're maintaining this. So that there's a sustained benefit, and these babies are now 5, 6, 7 years old in some cases. So the STRIVE was the confirmatory study. It again showed a marked benefit in survival as compared to the natural history study, as well as improvement in motor function. And this is the SPRINT study. And I just want to highlight that this is where the copy number is of interest, because the babies that are picked up on newborn screening and have 3 copies of SMN2, you can see they're all doing phenomenally well, and they're all pretty much in the normal range, which is this gray zone, on the Bayley scale. So not only are they sitting, standing, walking, but if you look at their comprehensive motor development on the Bayley, they're doing phenomenally well. Whereas the babies that have 2 copies of SMN2, you can see some of them are doing equally well. They're in the normal range, but some of them, even though they're doing great, they're sitting, they're standing, they're walking, they're a little slow to achieve these skills, and they're not quite normal in the tempo, in the trajectory of acquiring this when compared to typically developing children. So the point here is that it is really important to try to identify these babies, if possible, through newborn screening, and especially for those with 2 copies, there's an urgency, almost a medical emergency, to start the drug as soon as possible, so that we give these babies the best chance to improve in their motor function. So in conclusion, I think it's important that we consider that all symptomatic patients have the capacity to respond to these 3 drugs for SMA. But the expectations are different if you have a little baby picked up by newborn screening as compared to, let's say, a symptomatic baby shortly after presentation, or a baby who has more advanced disease, or a type 1 versus a type 2 or a type 3. And we know that symptomatic babies respond to the drug, and the earlier the treatment, the better, but we also know that pre-symptomatic is best. So as much as possible, particularly when there is a family history of SMA, you do want to look at other babies and test them for SMA with the genetic test as soon as possible after birth. And if they have 2 copies, again, I would urge you to try to start treatment as soon as possible. The next point is, well, which of these 3 drugs to choose? And that's a difficult question. It depends on what is the label, what's the availability locally, the cost, and also what's the preference of the physician and the parent. So there are a lot of factors that go into which drug to choose. But also, the one that you can get most quickly is sometimes the one that you want to choose because you want to start as soon as possible. And finally, I want to mention that it's really important, in my opinion, to maintain the standard of care support, even in these babies who are treated. Those drugs do not work in a vacuum. They don't cure the baby. You still need to look carefully at their weight gain, their pulmonary function, their swallowing, their motor function, etc. So you need to be prepared to address any features related to SMA, as well, of course, to address any of the management issues of the drugs, whether it be nusinersen with the lumbar punctures, or with the onasemagene, epaparvovec with the gene therapy related issues. Now, in Egypt, you're fortunate that you have a committee of experts who know how to do this. Okay, so that's really important, because it's not just giving the drug, but it's managing these patients after and during treatment and after, including the onasemagene, epaparvovec, the nusinersen, and the risdiplam for all of 3 of these drugs. So with that, I'm going to stop. I really want to thank you for your attention, and I hope we have time to take a few questions.
Dear Professor Richard Finkel, thank you very much for this very precious lecture. I am Dr. Murat Tadros, one of the consultants of interest in pediatric emergency, and looking forward in some critical cases of SMA patient. I only just comment before I open discussion. I might not agree with you for the last word you said. In Egypt now, we give a care for the after support and the training and the follow-up after management. We started, yes, a few months ago, and we get a very serious protocol and follow up the guidelines now, especially under the guide of our dear professor here in Egypt. They are giving a good care now after starting the therapy and looking forward for the nutrition, the physiotherapy, and the physical medicine. And we might have a very good results nowadays, and we hopefully within the few next months or years, we present papers, especially what's done in Egypt. So we already become clear about this point, because this is a point of succeed, no matter to give the management without a proper follow-up. So I do agree with you, sir. I will start that further now. Now we open the discussion. Anyone would like to ask Professor Henneken? Okay. I have 2 questions, if they allow me. First questions, What about your opinion about the combined therapy? Combined therapy.
Yes.
We take the decision, because I am talking from the field now. We're taking the decision to start, to prepare some cases for the gene therapy. But sometimes, as you say, time is management, or the time is new, as you say to us. Sometimes, for this time to prepare, to give them this therapy, or this expensive therapy, they are not suitable, are not fit enough for the criteria for the gene therapy to start it. So we obliged, if we have the fund, to start it a proper, say, the protein modulator therapy. So what is your opinion about this situation?
Yes, thank you for that very important question. And I don't think there is a clear answer yet. This is actually a very difficult topic that we're struggling with in the US because first, we don't have data yet that really convincingly shows that by adding a second drug or switching from one drug to another makes a difference. There are some studies underway to try to identify this. Is it safe to do this, and is it effective? The other point is that these drugs are expensive. So is it really appropriate to use two expensive drugs until you understand if there's a clear benefit and what is the risk? So at the moment, there are maybe three situations that we need to consider. One is where let's say the doctor and the family prefer the gene therapy, the anasemagene abiprubart, but the baby is tested and has a high antibody level. So it prevents treating with the drug at that time. So you have to wait, and I'm talking about the babies identified early in life after newborn screening. So they absorb the antibody from the mother. But if you wait, that antibody level will go down. But you may have to wait a month or even a few months. But that's not a good idea. So you have to start, in that case, with some other drug, either the nusinersen or the risdiplam. And then when the antibody level comes down, you have to make a decision. Do you switch over? In other words, do you stop the nusinersen or risdiplam and then give the anasemagene abiprubart? Or, if it's possible, do you continue those drugs? Do you give them in combination? And that's where we simply do not have any data yet to say, is it safe to do that? And does it make a difference? The other situation is where the drug simply may not be available yet. Let's say the family wants the anasemagene abiprubart, the physician's recommending it, but there could be a delay until it's approved and it's paid for and everything. So you don't want to wait to start treatment. So if another drug is available, in my opinion, you should start that. The third situation is even more complicated. And that's where a baby's been treated already with the anasemagene abiprubart. The baby's doing well, is showing a good response. But then the question is, if you add another drug on top of that, will there be some sort of synergy, and will the baby do even better? And that's where we simply don't have any data, but there are two studies underway. One to add nusinersen, and the second would be to add risdiplam shortly after the baby has already received the anasemagene. So if you can ask me that question again in maybe 2 or 3 years, I think we'll have a better answer. But right now, we simply don't really have a good way other than to say, if we do it, we need to watch carefully for the safety, because we don't really know, again, when you start mixing drugs, are they having a combined benefit, and is there a safety risk?
Thank you very much for that. I think we have started some trials like that under the supervision of my professors, and hopefully within a couple of 2 years, we see the same sitting and present our studies. Okay, this is my first question. My second question, okay, considering the hyperdose therapy for nusirensen, the hyperdose therapy of nusirensen. Okay, what is your opinion? And if you are thinking how to modify it, if we get a good results, how to modify this hyperdose?
Right. So that's an important question because we know that nusinersen works. And it works from the little babies, it works for the adults. But I want to share with you a little story. When nusinersen was in clinical development, it became apparent that this drug was doing things beyond expectation. That we thought at first, at least when I was involved in the clinical trials, I thought, oh, this drug is going to slow down the rate of decline and it'll stabilize these babies. But in fact, we saw that these babies were improving in their motor function. They were improving in their survival. And once we saw that, once that was recognized, there was a discussion with the regulatory authorities, the Food and Drug Administration in the US in particular, and there was an urgency to get a drug out available to the general population. So there was a push to get this drug approved by the regulatory authority and make it available. But in doing that, we never really tried to answer the question, did we find the optimal dose? We found a dose that worked and was safe, and that's the drug that's now available commercially. This study, which is being, it's called the DEVOTE study, is to look at what is hopefully the optimal dose. And this was developed by using a lot of the information that's been accumulated the last 6 years, using what's called PK/PD modeling, looking at pharmacokinetics and pharmacodynamic responses, and trying, using the computer, to identify what we think is the optimal dose to get the concentration we want in the spinal fluid. So this study is interesting because instead of the 4 loading doses, there are 2 higher doses that are given. So they're higher doses and they're given less frequently. And the hope is that it'll start the action more quickly also. And then the maintenance doses are also higher. They're 28 milligrams instead of 12. But they're still given every 4 months. So the discussion was you only want to change one variable at a time, right? So the idea was first let's optimize the dose. Is it 12? It would go up to 28 milligrams, hopefully, if it's shown to be safe and if it works better, and maybe works more quickly to start the clinical response. But then we have to decide what is the optimal interval. And we don't know that yet either. So that's going to follow. I will say that the company that makes this drug, Biogen, has announced that they're working on a next generation ASO. So it's possible that in the future there will be a new version of the drug. And the idea there is that the new drug may only have to be given every 9 months or maybe once a year. We don't really know yet. So this is still something that's under development to try to optimize the current drug, nusinersen, but maybe there will be a next generation to follow.
Thank you, Professor Finkel. I want to ask about, is there a protocol of choosing therapy for pre-symptomatic patients in United States? I know not all the states have the neonatal screening, but if I have a pre-symptomatic patient, do you have a protocol for choosing which therapy to start with?
Yes. Okay. That's a very important question. So at the current time, about 97% of babies in the United States are being screened for SMA. So it's not 100%, but probably in 1 year, it will be universal in the United States. So there's an important point here that the testing, the genetic test, picks up those babies that have homozygous deletion of SMN1. And that will pick up 95% of babies, but there's still 5% that it's not going to pick up. And those are babies who have a deletion of SMN1 in one allele, and they have a point mutation in the other allele. And the technology right now will not identify those babies. So there will still be a small number, about 5%, that will present later in life in the clinic. So it will not pick up every baby, is the point. And we're still going to have to be vigilant and watch for these babies, a smaller number, who are going to show up with symptoms in the clinic. To try to answer your question, we have some guidelines to say who should be treated, but we don't yet really have an idea of which drug to select. So let me explain a little bit. There have been a couple committees of doctors and experts to try to say, okay, if you pick up babies on the newborn screening, should they all be treated, and should they all be treated right away? And the answer is not necessarily. We do think that all babies with 2 and 3 copies of SMN2 should be treated as soon as possible, especially those with 2 copies, because we know that there's a very high chance that they're going to become symptomatic in the first few weeks or months of life. And there's an important paper that came out recently from Professor Eugenio Mercuri and his colleagues in Italy. And it showed that with careful clinical examination of babies with 2 copies, that about half of them are already symptomatic. Very mild, very early, but they're not entirely normal. So even the babies who are picked up with newborn screening with 2 copies, about half are already symptomatic. So that is pushing the urgency to start treatment. The question is, what about babies with 4 copies? The general thinking is, yes, they still have a disease, they're still losing motor neurons, but it's probably slower. So we think they should be treated as well, but maybe there's not so much an urgency to start. Okay. And maybe we need to look at certain biomarkers to give us an idea of how active is the denervation process. So that's a topic that we're going to learn much more about in the next couple years, I think. Now, the question about which drug, which is really your first question, which of the 3 drugs to select is very difficult because all 3 drugs work very well. So it's a wonderful problem to have, but we don't have an answer. I think in part it depends on what drug is approved by the regulatory authorities for your country in Egypt, which is available and can be purchased and made available to the patient. And I think also, where is there the expertise, excuse me, the expertise to manage the baby with this drug? Because each of those drugs requires a different type of clinical expertise. So it's not just administering the drug, it's to be able to manage the baby. So for example, with the gene therapy, the onasemagene epapervovec, you really need to have special clinical experience in how to manage the steroid treatment for the 2 months after the treatment, to follow for the liver function, to watch for any signs of liver inflammation or even liver failure. You have to watch the platelets for any signs of low platelets or thrombotic microcytic angiopathy, which occurs very rarely, but you need to be vigilant and watch for that. And fortunately, in Egypt, you have a very good system. You have a panel of experts that are managing these patients. But that's not true everywhere. So it's not just prescribing the drug, and I think, to be honest, all 3 work, so it's almost a matter of preference at the moment, but you do need to have the expertise to manage. So with nusinersen, you need to be able to do the lumbar puncture on these little babies, which takes some particular skill. Things like that, I think, really are important to keep in mind.
Last question, Dr. Richard. I ask about any age limitation for the ongoing trial of intrathecal gene therapy.
So for the age limitation, it's a difficult question to answer because it's different in the United States and Europe. In the United States, the onisamidine apapervavac, the gene therapy, is approved by the regulatory authorities up to 2 years of age. It doesn't matter how much you weigh, up to 2 years of age. Whereas in Europe, the EMA has approved it in a very different way. They allowed it for any patient with SMA up to 21 kilograms. Now, the original clinical trials only really looked at babies up to about 13.5 kilos. So we still have to get more experience between 13 and 21 kilos. Because again, this is a weight-based treatment per kilogram. So that if you have a 20 kilo baby or child, it's getting 5 times the total dose as a baby who's 4 kilos. Okay, and the higher the dose, the higher the possible risk of side effects. So I think it's difficult to say because also in some countries, the drug is only approved for those with 2 or 3 copies. So it has to do with several factors. It's not just age. In some cases, it's weight. And in some cases, it's the copy number, the number of copies of SMN2 that determines who is eligible to get the treatment. Now, there is this registry called the RESTORE registry, where we're trying to accumulate the data of all patients who are treated, not just with the onisamidine apapervavac, all drugs, but in particular the gene therapy, so that we can, I think, hopefully answer your question better in another 2 or 3 years.
Thank you. Thank you, Dr. Richard. Now we will close the session and proceed to the next session. Many thanks, Dr.
It was my pleasure.
Thanks,
Thank you.
Professor Richard Finkel. We really enjoyed the discussion with you, and we hope that next time you will be with us in Egypt to visit our centers. Thank you so much.
Yes, I look forward to that. Thank you so much.
Okay, consider
Bye-bye.
the invitation done. Thank you very much.
وفي تو announcements. احنا دلوقتي عندنا بريك بس هو هيبقى نص ساعة بس عشان نفضل في السكيدجول بتاعنا. هنبقى هنا الساعة 2 عندنا السانوفي سيمبوزيوم ليت اونست بومبي. تاني announcement في الشهادات اللي هي المعتمدة، يعني احنا خدنا اعتماد للمؤتمر كله 23 ساعة، بس طبعا للأسف الشهادة المعتمدة كل شهادة ليها ثمن، يعني فاحنا مش هنقدر we cannot cover. I'm sorry we don't have the budget. هي بحوالي 200 مصري، فاللي عايز هيكتب اسمه وبياناته عند الريجستريشن وبتوصله الشهادة بالإيميل، يعني هو مش مضطر ان هو يجي ياخدها او بتطبع او كده. فده in case you want the credit hours. شكرا.